Laurence, as you do a right portal embolization, even a drag and a double embolization, you just do a resection without problems, I think.
Okay, Guido?
I was just, because I don't want to appear as a Superman that propose fancy thing without proving. You know, the major problem in this perspective are not the big lesion, and not the big lesion in the contact with the middle hepatic vein on the major problem are the two lesions behind, on the left side of the right hepatic vein and in the paracaval portion. The two tiny lesions. This is the only issue that is doubtful. These two lesions. The other, you can do a parenchymal sparing. You can puncture or anyway do a right posterior sectionectomy, extend it a little bit to there, and upper resection of the segment 4 superior with detachment of the middle hepatic vein. Not just to understand, to let you understand the thinking, because otherwise I look like a foolish guy that is saying, well, we can do whatever. No, it's not like this.
Very well.
Some nodules, or would you resect them all? Would you resect them surgically all, or would you combine resection and thermoablation?
We try always to remove all. We did only 5 or 4 cases with thermal ablation, and I may say that in one case there was a liver failure due to the excessive liver failure of the microwave, because it is difficult to control the results. So it would have been better to, but if possible, and if it does not change the volume, the future liver remnant that we calculate, if we have margin, we want to remove.
Fernando?
Yes, thank you, Katsumori, great case. On one side, I agree with what has been said regarding chemotherapy-induced liver injury, only 4 cycles, and if it was oxaliplatin, you would be fearing of SOS, sinusoid obstruction syndrome. Yeah. And she received also bevacizumab, and it's known to be protective against SOS. So I think 4 cycles bevacizumab, that would be weird. And on the other side, when you see the spleen, I don't think it changed much between the first and the second CT scan, and sometimes you can see spleen or enlargement secondary to portal hypertension. So I wouldn't be fearing that. And regarding the second point, which is, okay, if you are going to do a right hepatectomy, you fear volume, probably you could do a scintigraphy to know the regional function of the future liver remnant before attempting occluding the right portal vein. Thank you.
So what did you do?
Can I proceed, move to the next slide? So I will summarize the course of this patient. After only 4 courses of chemo, significant response was observed, but ICG was 40%. The remnant, future remnant liver is 25%. So this is the performed in another hospital. They stopped the chemo for 3 months. And ICG was a little bit improved, but the disease progression was observed. And then the patient was referred to our hospital. So we first performed portal vein embolization of the right liver. And we continue the chemotherapy using S1. This is a compound agent of...
Sorry, what is S1?
No. S1 is made in Japan. I will show the final slide. Okay. The S1 is now key drugs only for not only for the colorectal cancer, but also pancreatic cancer, gastric cancer, and cholangiocarcinoma in Japan. We start the chemotherapy immediately after portal vein embolization for 4 months. Of course, after portal vein embolization, the future liver remnant was significantly increased. And then the ICG was significantly improved, almost normal after 4 months. So during this chemotherapy, we can keep stable disease. So no disease progression was observed. So we can perform extended right hepatectomy without any complications. So next, I will show you the second case. 73-year-old female. She was diagnosed as sigmoid colon cancer with multiple, very extended bilobar liver metastasis. She received modified FOLFOX6 and panitumumab, 30 courses, with excellent response. So we planned 2-stage hepatectomy, but the percent FLR was 34.7% and ICZ was 32.7%. Sorry.
Sorry?
So, okay.
This was around 6 months of chemotherapy. 13 courses.
30, yes. So maybe because of the long period of chemo, the liver chemotherapy-induced liver injury was developed. So what is the next move?
Chemotherapy, says Gina. Any other option? No.
Surgery.
So parenchymal sparing surgery. Tell me something. So you had the same result with the previous case. You stopped chemotherapy and you had a dramatic response in terms of ICG retention that improved a lot.
Actually, yes, but in this case, this patient was treated in our hospital from the beginning, so we never stopped chemotherapy. So can I move to the next slide? So I will summarize. She received FOLFOX and panitumumab 30 courses.
So just one information, so we are live on YouTube. So if anyone does not agree, should say it now. Okay, it's just an information.
Okay. So we first performed first-stage hepatectomy, which means the tumor cleaning of the left lobe and resection of the primary high anterior resection.
Are you going to do a 2-stage hepatectomy? 2-stage hepatectomy was the plan.
We planned 2-stage hepatectomy, and I first performed, of course, first stage. At this point, ICG was 36.7%. So we immediately start efruroicoblin and panitumumab. For focus, I mean, I exclude the oxaliplatin. It's a causing agent of liver injury. So after 3 months, ICZ was improved, reached to almost 18%, and percent FLR was 53.6%. So we decided to perform second stage extended right hepatectomy with alveolar resection. Post-operative cause is refractory ascites only. So I will show our policies. Stop chemo, of course, face of the risk of tumor progression, so continue chemotherapy without causing agent, which means oxaliplatin or irinotecan. So this is my opinion, but if we perform doublet and anti-EGFR antibody, setrusumab or panitumumab, we continue chemo with efruroicoblin and targeting agent. We exclude the oxali or irinotecan. If we perform doublet and bevacizumab, we have to consider the 6 weeks washout period. It's very complicated in such case, so we usually use capecitabine or S1. The point is keep stable disease until the liver function is improved. So this is the summary slide. Here I presented 2 representative cases of chemotherapy-induced liver injury which was successfully treated. The point is how to keep stable disease while waiting for the improvement of impaired liver function. So in case of setrusumab or panitumumab, just remove oxaliplatin or irinotecan. Considering the washout period of bevacizumab, we use S1, I'm not sure, only Japan, or capecitabine to keep silent disease. So I would like to ask all of you how to treat chemotherapy-induced liver injury. And this is the slide of S1. S1 is a compound agent, including tegafur, gimelacel, and otelacel. Tegafur will change to 5-FU in vivo, and then gimelacel stop the DPD, which accelerate the metabolism. So the effect of 5-FU is enhanced, and otelacel stop the becoming FUTP, which is called the side effect. So otelacel decrease the effect of toxicity. This is the S1. Thank you for your kind attention.
Thank you very much, Katsunori.
Thank you. Thank you very much.
Thank you. Thank you very much.
Oh, I can call Manuel Jaklic. Voilà.
There we go. Thank you. Good morning to all. Thank you much. So, the case of today is a 7-month-old male who was born prematurely at 32 weeks of gestation in a twin pregnancy with a stillborn brother. After birth, he had neonatal respiratory distress syndrome and was on mechanical ventilation for 14 days with a total of 1 month of hospital stay. At his dispatch home, he was diagnosed with a psychomotor development retardation syndrome and a congenital hydrocephalus. So about 7 months later, 6 months later, her mother came through the outpatient clinic with the complaint of a palpable-abdominal mass in the right hypochondrium and a failure to thrive. The clinical laboratories are normal with exception of, as you can see, alpha-fetoprotein of 60,500 units per milliliter. And following this, a CT scan was performed. This is the arterial phase with an early venous phase. There's a bit of a mix where you can see this large mass that is permanent in the left liver lobe, segment 2, 3, 4, and 1, with a displacement of the portal vein, and the arterial hepatic arteries are not visible in at this stage. So with this is the late venous phase. We can see the left hepatic vein and the middle hepatic vein involved in the tumor. You can see it here, where the left, the middle, right is free. So a liver biopsy was performed as must, and diagnosis of a hepatoblastoma with pure fetal epithelial differentiation was made. Glipcan-3 and beta-catenin positive, CK7, CK20 negative. And it is a liver-only disease at this stage. Immediately posterior to this, the pretext protocol was called in with the pediatric surgeons, and the pretreatment extent of disease was established. It was categorized as a grade 3, where one continuous segment is tumor-free, that is the posterior right segment. And the pretext therapeutic plan was built up and consisted of 4 cycles of cisplatin, vincistin, and 5-FU to assess surgical exploration after these 4 months. This is in January 2022. The second cycle of chemotherapy, the patient presented with pancytopenia. At that time, it was classified as a chemotoxicity. And as you can see, these are the blood CBC values. Alpha-fetoprotein is not decreasing in chemotherapy, and at the third cycle, we have 133,000 units. So it was planned to change of protocol to a high-risk plato protocol. And this was done for 4 more cycles. The second cycle, you can see alpha-fetoprotein is now down to 7,400. At the culmination of these 4 cycles, for a total of several cycles, alpha-fetoprotein is at 2,234. This is in July 2002. A new CT scan is performed with a massive reduction in tumor size and the visualization now of the hepatic artery. Sorry, and you can see the left hepatic artery. I don't know if you can see my mouse, yes. The left hepatic artery goes into the tumor here, but the right is free. Right anterior, right posterior sector. And on the side view, you can see how the left portal vein hugs the tumor here in segment 3. At this stage, this is what we achieved in 7 months of neoadjuvant therapy. Now, a post-text 2, and it was decided for a left hemipectomy with segmentectomy 1, with regional lymphadenectomy, surgical time of 90 minutes, and 2 Pringle maneuvers of 10. It was an R0 resection. The closest margin was 4 millimeters, 0 of 8 nodes, and an M0. Patient is discharged postoperative day 6, with the grade A bile leak, which in 9 days post-op was resolved. So 6 weeks after the surgery, patients at home comes in the outpatient clinic with the second episode of pancytopenia. At this stage, we cannot associate it to chemotherapy anymore. So a bone marrow biopsy was performed and a pancytopenic medullary was diagnosed. Thank God, I hope you all do in your institutions, we have some people in the background who do great work. And somebody thought, let's run a bone marrow failure panel on this child. With good luck, they found a mutation in FANCC gene. And this is something also new for myself. And posterior of this information, I got introduced to this handsome senior. This is none other than less than Professor Fanconi himself. So we have a Fanconi anemia patient with a hepatoblastoma. We had to change the post-text management immediately. So adjuvant chemotherapy was suspended and a bone marrow transplant was proposed at one stage. In between these managements, the patient did the 4th episode of pancytopenia. This is 7 months after surgery, and associated with a multifocal pneumonia, and sadly passed away at this stage. So this was all a bit shocking for us, because whoever has managed hepatoblastomas knows that the overall survival of these patients are very good, between 80 and 90%, independently if you transplant or you resect. They do very good. Even at higher ages, up to 4, you still have a good survival rate. So what is happening? What happened here? So looking a bit into Fanconi anemia, really there are about 2,630 tumors in solid organ associated to people with, also patients with Fanconi anemia, and the liver is the 3rd one in range. After the brain, Wilms tumor, it's the liver. So about 30 plus liver cases have been described in same situations. But what has happened? Well, if you search the literature, you will find yourself with lots of case reports, interesting cases, case studies, and clinical observations, and most of them, sadly, end with a similar problem that this patient faced. So here comes the question: should we bone marrow transplant these patients before we do liver surgery or chemotherapy or liver transplant? Well, there's not much information either, and there is this 47 reported cases where bone marrow transplant was made prior to organ transplantation. This includes not only liver, it includes also kidney and etc. And they found out that the mortality rate was at 71% if you do the transplant in the 4 months after the bone marrow transplant. But 4 months with somebody with this kind of pathology is it's not manageable. So what they found out also is after 4 months there was no mortality. But you cannot wait the chemotherapy for 4 months until you do it, but it doesn't work. So where are we today? Should we stratify the risk of these patients differently and can liver transplantation be considered an option in these patients as a combined liver transplantation? Thank you.
Okay, comments? So I would say, for example, in this case, I don't think hepatoblastoma is something that we have a lot of experience, as most of us treat adult cases. But still, I've never heard of a
It's a bad, let's say it's a bad, that's why the title, it's hepatoblastoma alone is manageable, and you have fairly good results. Now, you cannot suspect congenital abnormalities in each patient who has hepatoblastoma. It's also, you cannot test everybody for this. It is not, you can't do it in practice. But for these special groups, especially here, even if it's a small number, it's only 47 cases, with this 48, maybe there should be a protocol developed for this, or small one. So you check this first if you have this.
Does anybody have experience with this? Eduardo.
We have had some experience in treating patients with hepatoblastoma and received previously chemotherapy. In some patients, we have the opportunity to resect them. In some patients that the tumor recur, we have chemo again and transplant the patient, but we have not had the experience of the patient with a bone marrow transplant. So we have not this experience. But the results in hepatoblastoma with transplant or with resection after chemo in this patient is really very good.
I should say also the same thing. We have almost 20, we are reaching perhaps 20 cases of hepatoblastoma, excellent response to chemotherapy, excellent results after resection with a very high survival.
Completely agree. The survival for hepatoblastoma, if you independently, if you transplant or resect, as long as they get chemo prior to, like the pretext, is at 80 or 90%. For transplant at 85%, even at 12 years. So these are great results. It is so. That's why this is so shocking when you can't manage an hepatoblastoma, like we say.
And I can add that in most of the patients that we transplant, these small patients, we use in all the cases living-related donors.
Okay, Lee, and then
question
Ricardo.
about experience with hepatoblastoma in adults. I just recently took care of a 60-some-odd-year-old patient, otherwise unremarkable, with no significant history that would have alluded to any of this, with hepatoblastoma. And this is confirmed by our GI pathologist and reconfirmed in another hospital, because I guess the fact was that none of us had seen this pathology in this age group. So we leaned on our pediatric colleagues to know best how to take care of this patient. Was something, I mean, I have to admit, none of us had seen. So we did a resection, negative margins, patient did very well. The real question was, what do you do with this as more of a complete treatment, global treatment for this? Do others have experience in this age group that we might be able to benefit this gentleman from? It's a very unusual one-off. I have no other experience.
No experience also.
No.
This patient is 7 months.
Pediatric oncology decided, well, it was proposed. We didn't have time to perform the bone marrow, but the treatment of Fanconi anemia is a bone marrow transplant. The thing is, normally the evolution of this Fanconi anemia does not start at 7 months of age. It normally starts at 5 years until teenage years. Now, the hypothesis here is that due to chemotherapy, well, that this crashed the patient into having an earlier onset of this disease, because, as I said, the first episode we associated to chemothotoxicity, but after you have a patient over 7 months without chemotherapy, where do you associate pancytoplasia? You cannot associate it to chemothotoxicity, and this is so complex.
Ricardo.
The problem, congratulations, Manuel. The problem here is that to treat the Fanconi anemia, you should bone marrow transplant the patient with an hepatoblastoma. So the protocol is impossible. Or you transplant the patient without chemo, and you don't know the results, because the only thing we know of resection and transplant is after chemo and excellent responses. Here, probably the trigger was the chemotherapy in the Fanconi anemia. You cannot bone marrow the patient, because you have to immunosuppress the patient after bone marrow transplantation, and the hepatoblastoma will explode. So Here, the only option is to transplant the patient without chemo, and knowing not the results, you have to take the risk. Probably the result will be particularly the same. Even though if you knew the patient had Fanconi anemia before you treat the patient, it is a very hard decision to make. Or you take the chance to do chemo, knowing that he can zero the bone marrow and we will die of sepsis. Or you transplant the patient without chemo, and you don't know what's going to happen in terms of the tumor and in terms of the Fanconi anemia. So probably these patients with the association of hepatoblastoma and Fanconi anemia could have a 95% chance of dying.
Yes, that's basically yes. And there are cases that a bone marrow transplant has been performed before a solid organ transplant, including liver, but you need to wait 4 months between one and the other. And in these 4 months, you cannot treat the patient for the hepatoblastoma, so you don't know what stage you will encounter this once you're done. And it doesn't help to treat the Fanconi anemia if afterwards you have a grade 4 hepatoblastoma. So,
and actually, I have to think that the frequency of this type of complication is very low.
yes.
So probably we shouldn't change our approach, I think. But Gina.
I just have a quick comment because your case is very interesting and I had the opportunity to see what they do, but you have to just think to be more pragmatic, especially this case. So that's why I asked you how old is the patient. You told me 7 months. So now you have to make a decision regardless of what the science tells you. And I agree with Eduardo. For these patients, especially at that age, you have to think about living related. And it will be a monosegment transplant. That's what you have to discuss with the family. And it's monosegmental transplantation. You have to think first about the liver. Then you consider the oncological process.
Yep.
This is the case of saving life of a baby. So first step, I do that. Then I treat the second step, the oncological. I might give you, I mean, that's the work of Moreo Kazahara in Tokyo. He's only dealing with pediatric, really infant transplantation, and he has a great experience in that case. But that's what would be my first approach for this patient.
Okay,
Think pragmatically.
We have to move on. Thank you very much.
Thank you.
And I call Marcelo.
Good morning. I'd like to say that it's a pleasure for me to make part of this selective group of visionary surgeon under the leadership of Professor Bismuth. We have participating for many meetings for a long time in Brazil, 2016, in Portugal, the presidential house. And I know that it's very difficult to organize a meeting like that, and I congratulate Guido for the nice meeting that I had the opportunity to see the sparing the parenchyma liver surgery here with him. It's very, I congratulate because it was a big surgery, a good surgery. So I will present the case as a male, 15 years old, single, main complaint of change of bowel habits with losing of stool and blood. He had a loss of 20 kilos in 4 months, no relevant past history. He had an excellent performance status, and the physical exam was normal, except for the friable and ulcerated stenosis lesion at 3 centimeters from anal verge. The laboratory workup was normal, accepted by the CEA, that was 35, and the colonoscopy of external service showed extensive and friable circumferential substenosing rectal lesion at 8 centimeters starting at 3 centimeters above the anal verge. And the pathology report of another center was adenocarcinoma. The CT scan, the previous center was this. Multiple lesions in almost all these liver segments. MRI. Multiple confluent lesions in the right liver, but in the left liver also. And this is the total presentation that the disease. And the rectal, there was a massive lesion, the lower rectum, with invasion of a seminal gland, no definitive plane of section between the tumor and the gland, and multiple lymph nodes in the fat beside the rectum. This is the report of the CT and MRI. And I ask you if it's, at first, if it's resectable, which approach would you do to this patient? And if it's not resectable, which is the approach in terms of chemotherapy or palliative care, or any other strategy? Symptomatic, yes, bleeding and pain. Excuse me? T3 is, yes.
Okay, Mark and Laurence.
I would maybe go pragmatically 5x5 radiotherapy of the rectum and then chemotherapy and wait response and see what's happening.
Laurence?
It's a very advanced disease, rectum and liver mainly. So we would do a strong, very strong chemotherapy, what we call induction chemotherapy for FOLFIRINOX plus targeted therapy, because we want a fast and important response if it's one day curable. But that's what we do, a strong, very heavy chemotherapy, which will be efficient on the rectum, on the symptom of the rectum, and on the liver. So 6 cycle, 4 cycle, and then evaluation.
Rashad?
Neoadjuvant radiochemotherapy and heavy chemotherapy as well, and then reassess.
I would in fact, John, I would in fact postpone radiotherapy at this point, because for now you need systemic chemotherapy and wait for a response to think about local treatment of the rectum. I would have the same opinion as Laurence. John?
I think we all agree that he needs induction chemotherapy and restage. And treatment, symptomatic treatment, radiotherapy, yes, but is he obstructed at this point in time? Is the patient bowel obstruction?
This is not obstructed at all, but it's close to obstruction.
You know, you may need ileostomy or colostomy while it's...
Became non-systematic after 1 or 2 cycles.
Okay. So the tumor boards decide to, it's a rectal tumor with synchronous bilateral liver metastasis, like you told. No extrahepatic metastasis, good performance status. So we decide to perform the loop colostomy And liver first approach after observing the response to chemotherapy. We decided like for FOXFIRI, 7 cycles with good tolerance. And the patient had a wild type RAS mutation, no mutation, MSI negative and BRAF negative. And due to the toxicity, we changed to irinotecan and cetuximab 2 cycles. It was during the pandemic. It was very hard for us to obtain the chemotherapy in Brazil. It was a difficult time. And the CEA decreased from 117 to 23. The CT scan after the chemotherapy, the patient had a good response, recovered the weights, and it was very good in terms of clinical response.
So Marcel, just one question. You just did 9 cycles of chemotherapy.
9.
Why wouldn't you go to propose surgery before that? Because it looks like an excellent response, and probably after 4 to 6 cycles, you would already have a good response.
Yes, in fact, at first we didn't think it would be good to make the surgery before, and we, like I told you, you had many difficulties to operate this patient before, so it was hard, and I think we wait for the excellent response to the chemotherapy. So the the MRI, we have radiological good response. This is the final exam. And the rectal, we could see a restricted lesion close to the gland, but without lymph node visible on the fat, perirectal fat. So we decide for the liver resection.
For the optimal timing for rectal surgery, we would perform the liver surgery. And you can treat the patient in one stopping chemo time.
Yes, it could be.
Normally, in these patients, we do the radiotherapy, and we schedule the liver surgery in the 12 weeks that we are waiting for the time of radiation.
Okay, but we performed before the surgery, the liver surgery. The liver was good. We performed the ultrasound. It was interesting because the left side, we could not see the most part of the tumor. The palpation, we could not feel the tumor. It was interesting because we have seen just the 2 lesions on the left, and we performed the right hepatectomy. The liver was good, like that. And we removed all the lesions or the scars that you could see. And the ultrasound could not see any other lesion on the liver. It was an excellent response. It was good for us, for the patient. And the pathological specimen, there was a complete pathological response in all the lesions of the right side, the right liver. Like we have a dystrophic calcification. The liver, normal livers here. We can see no can see any cells, tumor cells in this region of the tumor. The other two tumors, segment 3 and segment 4, the same, complete pathological response. We had sclerosis of the tumor, the liver normal, calcification. We could see also the xanthogrammatose macrophage in the entire region of previous tumor. You can see the macrophages with xanthogrammatose fibrosis, but any sign of cells. So we had an excellent response, total response. We decided to perform a short course of radiotherapy in the colorectal resection. The colorectal group performed the mild surgery because it was too lower and then compromised the sphincter and the anal verge, and it was completely dysfunctional. And there was also a complete pathological response in the colon. We have 2 exams after this surgery in September 2022 and 2023, March 2023, with no evidence of disease. PET-CT also, we could not see any viable tumor. So it's a little bit discussed, this subject. It is not just the patient with total response. We have this new paper, Chinese paper, 2020, with almost 500 patients and 30 pathological complete response. It had 6% of pathological complete response, and there will be 70% of any experience of recurrence, cure of the patient. And when they did the univariated analysis, it found that the irinotecan-based chemotherapy is association with the complete pathological response. In the multivariated variable analysis, they found T category, T1 and T2, right colorectal primary tumor, tumor size in the liver less than 3 centimeters, and preoperative CA less than 20. They are the results associated in the multivariable analysis. You can see clearly the benefit of this response, 85% of the patient in terms of overall survival rate in comparison to the patient that didn't have complete response. And disease-free survival rate also 73%. It's like a cure of this patient. So with the discussion that you had previously in this room, we asked about until when will this kind of disease will be treated by the oncologist without the help of the surgeon. For sure, like Professor Adam said yesterday, we always have to operate the patient to prove that there is a complete response, and that radiological exam is not enough to say or to guarantee that we have a pathological response. So I want to hear you.
Thank you. So, So time for one quick question, and then we close the session, Mark.
Very short question. Why did you operate the rectum? You had a complete response of the liver. You know that then very often the rectum is complete response. In the Netherlands, we have 20%, 15, 20% complete response. We don't operate. We just follow up with MRI, biopsies, echo.
Yes, it's a good discussion. It's a good discussion. They had, it was not decided by our group, it was decided by chiropractor. It was completely dysfunctional, the rectum. And I think they didn't have they were not sure about the complete response. Perhaps it was because of that. They tried to reconstruct the transit, but there's infiltration and fibrosis of the anus. It was impossible to reconstruct.
Okay.
Okay, thank you.
Thank you.
All right, thank you for all the speakers. I have to close the section, and we go to the interval. Thank you very much.
Intéressant ton cas. J'ai eu, c'est pas complètement par hasard que j'ai eu.
thanks everyone for coming. Nowadays we will start the meeting, and before Professor Bismuth we start the opening ceremony, there is the General Manager of Humanitas that is here to present the greetings of our institution that is hosting us for this nice event.
Welcome, everyone. It's a pleasure for us to host the International Symposium on Hepatobiliares surgery here in Humanitas, and we are really glad to welcome Professor Harry Bismuth here. It's an honor to have you here today. And thanks also to Professor Guido Turzilli to organize here this meeting. At Humanitas, we strongly believe in quality, in clinical quality, and in quality of service for patients. Words such as outcome, readmission rate, patient experience are a common language for doctors, nurses, but also for all the staff involved in the organization. We treat every year with surgery, chemotherapy, and radiotherapy more than 7,000 patients with cancer disease. And cancer treatment represents more than 30% of revenues of our organization. So we know that to make quality and innovation, one point is crucial, is comparison, benchmark, sharing of ideas to understand where the borders are and how to overcome them. So today we have more than 50 surgeons here, more than 50 companions coming from all over the world with this goal, understanding borders and how to overcome them. So just a few words, thank you to being here, and I wish you, in Italian, buon lavoro.
Grazie Riccardo, thank you very much to Dr. Bui. And I ask Professor Bismuth to start the opening ceremony.
Mr. Director, dear colleagues, dear companions, our superb organizer, Guido, gave a name to our meeting, When Innovation Meets Tradition. So I would like to start by innovation. And for that, I have the idea to go to the metaverse in order to find my avatar. I asked the technician, I hope he will succeed to open the cloud and to find my avatar. I know him, I speak with him, he will introduce the compagnon, I hope. He speaks in English and he has a problem with his tongue. He said that he wants to improve my English and to speak with the way the English are speaking with this kind of movement of the tongue, but I think it is too much, he exaggerates a little. Let me think easier. Yes. I introduce E. Henry. He's a very good speaker. Many thanks, Henri. You have always the good word. Okay. It is a real pleasure to open now the second part of our meeting. Let me tell you, for those who don't know, what are the compagnons? I know that, I will do it. Please, Henri, don't interrupt me while I am speaking. Please, let me go on. The compagnons are a group of surgeons who train at Paul Brousse Hospital with me, and more recently, all over the world, by the Compagnons themselves. I consider it as a family with son, daughter, and now grandson and granddaughter. The important thing is that they share the same spirit in the practice of surgery. It's all very short. You always say that I speak too much. Okay, thank you, Henri Bay. Let me now continue to introduce the Compagnons. You see his house, a beautiful house with a sea on the, and you see the painting. It shows beautiful painting. Okay, thank you, Henri. And now I would like to introduce myself, the Compagnon, not him, and I will ask you to come with your name, please. The Compagnons are here. Some are not arrived yet, but anyway, I will give you. Eduardo Santibanez, please come, be in front, we take the photo. Eduardo Santibanez for Buenos Aires, Oscar Andreani for Buenos Aires, Rodolfo Rossi. No. All your applause until the end. In front. We take a photo. Then Fernando Alvarez for Cordoba, Valerio Lucidi, Bruxelles, Belgium. From Brazil, Antonio Calil, Porto Alegre, Carlos Eduardo Santos, Rio de Janeiro, Marcelo Linares, Sao Paulo. From Colombia, Juan Manuel Rico Juri from Cali. From Egypt, Rachad Al-Masri, please stop your photo, come here. From France, Jean-Philippe Adam, Bordeaux, René Adam from Villejuif, Philippe Bachelier, Strasbourg, Laurent Chiche from Bordeaux, Marc-Johan Metz, Gina Crissat from Paris, Françoise Bonhomme from Villejuif. From Ireland, Oscar Trenor is not here yet. From Italy, Fulvio Calis, Gennaro Nuzzo from Roma, Fulvio Calis from Napoli, Riccardo Pellicci, Petra Ligure, Guido Torsili, Milano, of course. From Japan, Katsumori Imai, Kamamoto. From Netherlands, Mark Bebelmans, Maastricht. From Poland, Krzysztof Jenewicz, from Warsaw. From Portugal, Eduardo Barroso, Lisbonne. Hugo Pinto Marques, Lisbonne. Ricardo Martin, Coimbra. Guilherme Traio, from Coimbra too. From Turkey, Ibrahim Astarcioglu, Izmir. Switzerland, Pierre-Alain Clavien, Zurich. Alexandra Cristodi, Lugano. Pietro Maino, also from Lugano. Christian Tozo from Ginevra. United Kingdom, John Isaac from Birmingham. Please, John. From United States, Dimitri Alden, New York. Lee Gordon, Nashville, come. Tomoaki Kato is waiting the transplant in New York. Andreas Katz is coming, I hope. Jorakua, New Jersey. And Nicolas Jean Voté from Houston. Thank you all of you. And please now, take the picture. All the Compagnons are here. Thank you for coming, all of you. Pietro. Thank you. And now we continue the welcome ceremony. Guido. Where is Guido? No, Guido. No, Guido to give a talk. Not just
Are you going to speak again? Or I come begin?
You will start to the moderation. No, I just introduce.
Okay.
You want that I say something, that's all. But Eduardo, 1 minute, 30 seconds. So, Professor Bismuth recommended me to say something as a local organizer. I just want to thank all of you for coming. Also thank for all of you for the patience that you have had. And sorry if something is wrong or the organization was somehow troubling. more and more difficult to do this event in the actual times, but thank you to all of you and to the institution and also the venue, which helps a lot in terms of facilities. I'm really pleased to host you and to have all of you here. It's Compagnons is a great opportunity to have the 90% of the best surgery in HPB world together, which is uncommon, and they uncommon unless you are organizing a World Congress by the official societies. And having them spontaneously and very happy to be here is an additional element that make all of us excited to join and to follow the, I may say, the real pioneer of HPB surgery in the world, and he's the only person that was able to build an hospital on HPB once HPB was just an idea, more or less. And this hospital is still, when I visited it the first time, it's really a model for a modern hospital today. And then I was really impressed. And then it's my great pleasure to be honored to have the task to have hosted you here in Milano. And that's all. I don't want to, otherwise everyone is too emotional. And let's start. Professor Barroso.
Okay, let's go to begin our symposium. But I would like to say that I tell you, it's a big privilege to belong to this Compagnons Hepatobiliaires. And I must say to you that nothing in Lisbon was possible without the support of Professor Henri Bismuth. Our center in Lisbon is a real metastasis of the Paul Brousse idea from my older brother. And really, now I am retired, but I want to continue to come and meet every one of you, because this is our family, really. And please accept again our fantastic support that you have done to our center in Lisbon, that now Hugo is the director. Ricardo, it's a pleasure to be with you. So to begin, I give you to the word. Excuse me these simple words, but I needed to say that.
You said what I think everybody is thinking. So we start with our session. I want to call Christian Torzo. Yeah. Okay. You just arrived. So you said.
So thank you very much, Mr. Bismuth, Guido. Very nice organization, so it's a pleasure to be here with you today. But a bit unusual, today I would like to discuss some basic science and not some clinical science, and look and explore with you the impact of portosystemic shunting on HCC. Of course, we all know that the gut is connected to the liver, and this builds the so-called gut-liver axis. We also know that there are many bacteria in the bowel, and that in the presence of liver disease, both in mice and in humans, there is an increased leakiness of the bowel, releasing some bacterial products into the portal system. As a result, and here more present in patients with decompensated cirrhosis, you see more LPS endotoxin in the portal flow, increasing with the Child-Pugh score. And with that in mind, we can think that there is the potential to build a vicious circle. You have a chronic liver disease, this increases the portal pressure, alters the bowel, and increases the pro-inflammatory bacterial-derived product translocation into the portal system itself, impacting the liver and worsening the chronic liver disease. And all of that has the potential to have and to increase the risk of HCC. And this circle is also supported by previous data here from another group demonstrating that in mice, in a model of HCC induced by the injection of DEN, a toxic carcinogenic drug, with the addition of tetrachloride, you see that these mice, wild-type mice, develop HCCs. But when you perform the same treatment in mice that are TLF4 mutated, so with no potential for the LPS to link its receptor, the TLF4, you prevent the development of the HCC. And this shows that the LPS TLF4, the gut-liver axis, can be cut and prevent the HCC. It is also the case when you clean the bowel, less bacteria, by giving antibiotics, you prevent HCCs. When you use germ-free mice, you prevent HCCs. And vice versa, when you give LPS, you increase the risk of HCC in these mice. Some other data from our lab looked at the similar process, but this time not looking at de novo HCCs, but more at the potential for circulating HCC cells to engraft and grow in the liver. And again, we gave antibiotics, TLF4 antagonists, and we used TLF4 knockout mice. And we demonstrated it's the three last conditions that by cutting this axis, LPS TLF4 axis, again, preventing or cutting the gut-liver axis, you prevent the development, or more precisely, the engraftment and the growth of HCC cells in the liver in this specific model. So now the question is, now that we know, or we can assume that there is a vicious circle, the question is that, is there a way to cut and to prevent this vicious circle by performing a portosystemic shunt, which would decrease the portal pressure and hopefully preserve the bowel, decrease the release of bacterial products in the portal system, and ultimately potentially preventing an ongoing insult to the liver and the chronic liver disease. The idea would be to preserve the liver itself, but also to prevent the HCC. For that, we used mouse models of HCC with or without shunting, and we monitored them up to 40 weeks. We looked at the development of HCC, and the two models were one, as stated earlier, a model of high-fat diet-fed mice injected with DEN, this carcinogenic drug, and the other model used lap-MYC mice, which are overexpressing the MYC oncogene and demonstrating an increase or demonstrating the presence or the development of HCC in the presence of a choline-deficient diet. The portosystemic shunting was performed by performing a small incision over the spleen. The spleen was taken out. We were making superficial scratches on the spleen, inducing a light bleeding. The spleen was positioned in a subcutaneous pouch, and with time, in fact, relatively quickly, over 2-3 weeks, you see when performing a CT scan on these mice the development of a collateral vein in 85% of the mice, and we, of course, only use those that have a demonstrated shunt. With that, you can decrease the pressure in the portal system almost back to normal conditions. It's the CD control diet mice, and significantly lower than what we can see in the high-fat diet-fed mice, the dark blue mice, which show an increased portal vein level. This had an impact on the liver. Here, looking at the SAF score and looking at the histology of the liver and demonstrating a decreased level of steatosis in these mice. Of note, we were not able to see a decrease in the activity of the fibrosis stages. This may be related to the fact that these models do not develop much inflammation or fibrosis as a baseline. And this was also confirmed when assessing automatically the steatosis, again confirming a decreased level of steatosis in the liver. So shunting could prevent and decrease the insults to the liver. Now the question is, what is the effect on the HCC? And when you look at the human literature, there is no convincing data. Some papers say or state that there is an increased risk of HCC linked to the presence of a shunt, of a TIPS, for example, and some others state that it is a decreased risk in the presence of a TIPS. In these models, we have shown that with time, there was a decreased risk of developing HCC, so a decreased carcinogenesis, which was not much visible at 28 weeks, so we had to wait quite a long time, up to 36 weeks, to demonstrate a significant difference between the two groups, here in the DEN-injected mice. But this could be reproduced, so it's solid data. We performed this specific experiment twice, and then we confirmed it also using the lap-mic mice, also demonstrating in the presence of a shunt a decreased risk of developing HCCs. Now the question is, why is it so? We can assume that because the liver is is healthier with less steatosis, it might be less at risk of developing an HCC. But we have also observed that in the presence of a shunt, the livers were showing less oxygen, almost back to the level of the control mice, and significantly with significantly lower levels than in the high-fat diet-fed mice without shunting. And it is known that HCCs are oxygen-avid tumors, and to confirm that even further, we perform another experiment using other animals with DEN and a shunt with or without the artery. So in some of the animals, we're cutting the hepatic artery, and you can see that at 28 weeks, there was not much difference in the number of HCCs between the mice, but at 36 weeks, we were seeing a significant difference with less HCC, less carcinogenesis in the absence of the artery. So it matters, it makes a difference whether you have a high or a lower level of oxygen in these animals. So it has an impact on the carcinogenesis, the development of HCC. However, the surprise was that at the same time, also seeing a decreased number of HCCs, we're seeing an increased HCC growth. In these animals, we're performing repeated CT scans, and we measured each specific HCC and assessed the trend over time demonstrating the growth of these HCCs. And we demonstrated a significantly increased growth of the HCC in shunted animals. This is still something under exploration, but it could be linked to an increased inflammation in these livers. When performing microarrays in the livers, we could demonstrate a higher expression of various inflammatory genes for the S100A8, S100A9, both increase in the presence of an inflammation and known to be involved in liver disease and HCC. The same for the serum amyloid protein, also involved in HCC, and strangely, our friend, the TLF4. This was confirmed performing PCR testing in these livers, demonstrating similar differences. This is still under exploration, but it could be a way to explain the difference in the aggressiveness of the HCC and the increased aggressiveness in the presence of a shunt. But of course, all of that is mouse data, and we wanted to explore that also in human. And we therefore used and got access to the SRTR human database, which is a large which states and stands for the Scientific Register of Transplant Recipients. So it's a large US transplant registry. And we compared patients with and without TIPS and looked at the HCC growth and carcinogenesis for patients while they were on the waiting list. So we had access to multiple CT scan assessments while they were on the waiting list. As a reminder, there is more than 300,000 patients on that list, and we looked at the time period 85 to 22. We got access to a bit more than 2,400 patients with a TIPS, so it's patients with a Y for yes, and we compare them to patients without a TIPS, so 45,000 patients. And no surprise, there was striking difference between these two groups because patients with a TIPS had a more altered liver and they were more transplanted because of a decompensated liver cirrhosis, while they had lower and less and smaller HCCs. So as a consequence, we had to use a propensity score matching system based on age, gender, BMI, the cause of the underlying liver disease, but also the MELD score and the type of HCC treatment they received while on the waiting list. And at the end, we matched one patient with a TIPS with two patients without a TIPS, and we got similar baseline characteristics after matching between the two groups. And the interesting thing is that at the end, when looking at the behavior of the HCC, we have seen exactly the same setting and the same outcome and the same behavior as those observed in the mouse, with a decreased number of HCC over time in the presence of a TIPS. However, these HCCs tended to be more aggressive as they were growing more in the presence of a TIPS and showing higher levels of AFP. So overall, I understand this is still under progress. I understand this is still a bit weak, but it's interesting to see that both our mouse and human data are matching. When looking at the impact of shunting, they suggest a decreased risk of HCC carcinogenesis, may be linked to a decreased steatosis, may be linked to a decreased oxygen level in the liver, but at the same time, they show an increased HCC progression, may be linked to some higher degrees of inflammation. This is still to be confirmed, but it shows that maybe we should be a bit more careful when thinking of putting a TIPS in patients that are at higher risk or have already an established HCC in place. I would like to underline that this is the work performed by a large group, including Andrea Peloso, MD, PhD from Geneva, but currently in Pulbrook for a fellowship, and currently taken over by Sofia Elagi, MD, PhD student in my lab at the present time. Thank you very much for your attention.
Can I ask to Jean-Pedro to come here? Yes?
So thank you, Christian, for the paper. You have pushed me to read a lot, and I found just few things. But so the paper is great, talking about the basic science, but it's trying to explain something that happened in the clinics. When in the liver you have some decrease of the flow of the portal vein, you have an increase of the artery. So my first question is the finding about of less oxygen in this model when we are expecting that we are decreasing the portal vein is increasing the artery and you have more oxygen. And this is explained clinically in some kind of patients. The patients that have congenital portocava shunts, this patient is showed that they have more HCC and they have more nodal hyperplasia. So, and this could be related to a promotion of the reproduction of the some kind of surge of cells related to some growth factors. So my question is about one of the topics here is about the oxygen, how you can explain, or is the rate of the flow that you are decreasing. But I think that the paper is very important because it's explaining something that happened in the clinics.
So first, it's I agree that it is probably, at least in part, linked to the oxygen level in the liver. The ratio between the portal flow and the artery flow in the mouse is more in favor of the porta in the mouse. So this might explain why we can see this effect more present here in the mouse than in a human. Also, it's difficult because when you do a surgery and you clamp the portal vein, for example, and you look at the difference in the level of oxygen, it's difficult to see this effect, the hepatic artery buffer effect on the short course, because you can do it only for a few minutes. And of course, these effects we have been seeing were established over months. So it's extremely difficult to guess what's happening a few months later by performing assessments in the OR. So of course, as always, mice are not humans, so it's difficult to replicate it to be sure that they are really matching what is happening in humans. But on the other side, we do not have really good tools to assess that. We are currently getting access also to liver samples of patients that have undergone TIPS, had an HCC, and looking also at microarrays, both of the HCCs and of the underlying liver, to see whether we can see patterns that can match what we see in the mice, which is, I think, going to be very interesting. Yeah.
Christian, I have two questions. One, did you check the patency of the portacaval shunt in your animal? In my, it was my MD thesis on portacaval shunt on the rat, not on the mouse, on the rat. What I observed is that in some animals, they block the thrombose, the portacaval shunt, and the effect is totally nil. That means it depends the percentage of animal that you have, and you have to take care of this before exploiting the results. So my first question is that. The second question is about the type of portacaval shunt. Is it a end-to-side or side-to-side portacaval shunt? As you know, side-to-side is contraindicated for there is an aspiration of the portal blood with a thrombus of the tumor going fastly in the extremity of the portal vein and going even to block the shunt. But you know that in humans. So on your experimental work, what was one, if you check the patency of the shunt, and two, what type of portacaval shunt are you doing?
So unfortunately, we do not have your skills. So we were not performing surgical shunts, putting two vessels together, but we were using the trick I showed, with the spleen that we're scratching and putting in a subcutaneous pocket. And this had been described in the past as an efficient way to build a shunt. Of course, we were a bit not sure about the effects, but we took care of, one, measuring the difference in the pressure. I showed that. Second, we injected beads into the ileocholic vein to see the part which is going to the portal vein and the part going to the shunt, and we have shown the patency with about 1/3 of the flow going to the shunt and not to the liver. And in all the animals we have used, we performed a CT scan to make sure that the shunt was patent, and at the time of sacrifice, we were in the subcutaneous, we were seeing the vein just to confirm. And again, the shunts were patent, visible, and stable in 85% of the mice, and we only used these mice. So in the 15% without a visible documented shunt, we didn't use them for the experiment.
But as you know, the technique of direct portacaval shunt in the mouse exists already. It's more difficult, of course, but it is possible by microsurgery to do it.
Yes, but more challenging, and we needed something more established.
I agree.
So there is a time for another short question. No? No. Is okay. We can close. Thank you very much.
Well, let's pass for the Oscar Andriani. And after the discussion of Guido Trosili, liver resection based on Lennox capsule for cranial approach of hepatic veins. Please.
Thank you, Eduardo.
Oscar.
Well, thank you, Guido, for organizing this meeting. And I want also to be grateful with Professor Bismuth that gives the opportunity to share and to gather every year in not only scientific exchange, but also friendship from all over the world. So I begin with some anatomical facts. In 1640, Johannes Valles from Leiden described a tunica covering the portal triad going within the liver, accompanying this arteria, portal vein, and artery, portal vein, and bile ducts. A few years after, you all know Francis Gleason, who described perfectly and precisely in casts, described in Anatomia Hepatis, a famous book, the same sheet, and was during a lot of years recognized as the only sheet of the liver. But in 1802, René Laennec describes another sheet that is less connective and involves not only surround not only vessels but also some viscera. In this particular case, liver. So in this scheme, you can see in green the Gleason sheet that is covering and surrounding the portal triad and going within the liver, accompanying these elements. But in red, you have the Laennec capsule that surrounds not only the liver, the retrohepatic inferior vena cava, and also the portal triad within the liver in the distribution, as well as the Arancius ligament and the round ligament. And you can see the difference between a Gleasonian pedicle and the hepatic vein, which is not covered with the Gleasonian sheet. There is also some communications between the pedicles from the portal triad and the hepatic veins, and you can see how it is easy to detach this Laennec capsule that in some way we can say that acts as a barrier between the tumor and the vessels. Concerning the approach, the classical approach to the portal veins is from the caudal to the cephalic portion. It means opening the liver and going from down to the top. And you can see here, for example, how the hepatotomy begins from the lesser part of the liver. We used a pedicular clamping and the clamping of the hepatic veins in order to work in a bloodless field. And this is the result. You can see here the inferior vena cava, the right hepatic vein, the middle hepatic vein, and a portal pedicule in the bed of the resection. Claude Quinault described also two different approaches. The first one is the extrafascial approach, which is the more common, and the other one is the intrafascial approach. For the intrafascial approach, the extrafascial approach, sorry, you have to dissect the connective tissue surrounding the confluence of the hepatic veins, and we can see here the lamina of the cardiac part of the Lennec capsule. So we can have an extrafascial approach. The intrafascial approach, we have to open slightly the cranial part of the liver, going from the top to the caudal part. And for that, I will show you this case about a single liver metastasis. The primary was resected in 2019. At that time, the patient was treated in another center and was considered unresectable for the liver. She began capecitabine and oxaliplatin, but she needed to stop due to toxicity. She had in 2 years a mild progression, but only in the size of the lesion, but it was only this lesion. You can see here the relationships between the inferior vena cava, the hepatic veins, and the portal triad. In this coronal CT scan, you will see the right hepatic vein, the right pedicle, and the middle hepatic vein at the tumor, very close to the inferior vena cava. So for the surgical planning, first of all, we planned to mobilize the right and ligation of Spigelian veins for the detachment of the paracaval portion of the caudate lobe, and then encircling the middle hepatic vein, as you see in the scheme. And then the cephalic approach of the Lennec capsule. This is intraoperative ultrasonography, the inferior vena cava, the middle hepatic vein, several branches from the left hepatic vein. This is a sagittal view. We begin with the detachment of the falciform ligament and the coronary ligament in order to access to the right hepatic vein. The right hemiliver was already mobilized. This is the right triangular ligament, which is also divided. And then with the right hemiliver mobilized, you can see here, so the Lennec capsule and how it is open in order to encircle with a tape the right hepatic vein. Then we continue isolating the middle hepatic vein, which was independent from the left hepatic vein. And this is the caudate lobe and the beginning of the dissection. Again, you can see the Lennec capsule, which is detached from the hepatic vein in order to have the dissection plane. Usually we use this water jet dissector, which works mostly similar as the CUSA. Again, as the tumor was very close to the main hepatic veins, we clamped firstly the pedicle and then the right hepatic vein. This clamping, we maintain 15 minutes of clamping and 5 minutes of declamping in several periods. And you can see how the vein is severed from the liver parenchyma. And you can see even with a window in the vein, there is not blood because of the clamping. The Gleasonian pedicle is dissected, and here we had to remove a patch of the vein because it was really very attached to the tumor. So we put a clamp, a lateral clamp, in order to resect a patch of the right hepatic vein together with the tumor. And you can see then the surface of the tumor that it was in contact with the middle hepatic vein, which can be seen in the deep of the resection. Also with in the plane of the Lennec capsule, in order to be as radical as possible. Tiny veins are ligated and divided. We continued with the harmonic scissors, and here the spigal lobe, the paracaval part of the coated lobe and the coated process. A running suture was performed in the right hepatic vein. And after that, we declamped. Here you can see then the right hepatic vein, the middle hepatic vein in the bottom, the inferior vena cava, and the other side also the resection of the spigal lobe. So in conclusion, the importance of the Lennec capsule as a dissecting plane for cranial approach to hepatic veins must be stressed, mostly for tumors close to the hepatic veins. The cranial approach to hepatic veins combined with selective vascular occlusion is safe and reduces risk of bleeding. And the dissecting plane along the Lennec capsules allows an oncological appropriate R1 vascular resection. Thank you very much for your attention.
Guido, first discussant. Guido, please.
I was prepared to discuss your talk, but I didn't expect you were showing R1 vascular. So I cannot say anything because I enjoy a lot your operation. It's exactly what we are doing, and I think that I may say that, in my opinion, the Lennec capsule is not really the key for driving the dissection of the hepatic vein. I consider the Lennec capsule a further protection to justify also oncologically the results of the R1 vascular, because it supports the idea that it is the vessel inside the liver are separated by the parenchyma, like the vena cava. So in reality, if we detach the tumor from the vena cava, we are detaching also the tumor from the hepatic vein, and then R1 vascular is a sort of detachment for a structure that is almost outside the organ, anatomically, and then justify the results. And I am pleased to see that your operation was really, I enjoyed a lot. I would have done a tunnel in this patient, but you suggested another approach. Just a segment, full segment 1 extended to segment 7 a bit. It was very nice. So I agree, it's a nice success, and I suggest you to send it to Anastosurgical Oncology. They will publish the video for sure.
Thank you. Thank you, Guido. Now open Pietro, please.
Thank you, Oscar. I really liked it. And I would like to ask a question to you and Guido. My impression is that the capsule, the Lennec capsule, in fact gets thickened next to metastasis. There is sort of desmoplastic reaction, and you can profit of that much more close to a tumor than you would in a normal dissection like a living donor.
That's completely true. I agree, Pietro. I don't know, Guido, if you want to say anything.
Oscar.
Also our
I have a
experience,
question.
and it drives you the best.
I have a question, Oscar. To be clear, the Glisson capsula, in fact, is in continuity with the peritoneum. Indeed, the Glisson capsula is the peritoneum covering the liver. Totally different from the Laennec capsula. And this is clear on the scheme and the drawing of Laennec. But what is interesting is that the sheet entering inside the liver is the one described by Laennec. It's not the Glisson. That means, if you agree, the Glisson pedicle are not Glisson pedicle, they are Laennec pedicle. Do you agree?
Well,
This is on the
Glisson, what we call Glissonian pedicle is covered, surrounded by the Laennec capsule. It means you have the Glisson sheet, but outside is covered also for the Laennec capsules.
But
so is that way is thicker than the other.
On the drawing, the first drawing, the Glisson is not entering the liver. You may see on the drawing of Laennec. Exactly. And that means on the hepatic vein, when the hepatic vein go outside the liver, it is covered by the peritoneum, but inside the liver, there is nothing. They are nude. It is clear on the ultrasound, there is nothing around.
Please. When at the time, please.
Pietro and Oscar.
Yeah, Pietro.
No, Pietro, please.
Give the microphone, please.
In fact, I don't think they are nude inside the liver. I think there is a separate layer between and a separate layer that becomes thicker closer to a tumor that you can profit from when you dissect. When you think that there is one layer on the hepatic vein, no, there are two layers. There is the layer of the hepatic vein and a further layer, and if you pay a lot of attention, like he did, you can detach two layers in the hepatic veins. This is what I found. I mean, I have a picture of that, but I don't know.
I agree with you, Pietro, but what is the name of this layer? It's not Glisson and not Laennec.
It's called the cardiac portion of the Laennec capsule, which is surrounding the inferior vena cava and the hepatic veins. As it's a Japanese paper that describes this kind of sheet.
More
You're
questions?
not convinced.
More questions about this fantastic anatomy history? Nobody wants to speak?
Resect a small part of the hepatic vein, so you resect a small part of the hepatic vein. Clamp
Yes.
and resect. Why?
Because it was so attached to the tumor was invading.
I thought that
differently.
R1 resection is possible. So why did you do that? If
Because
you are
it was
sure that there is two layers between the hepatic vein and the tumor.
Case, and Guido could tell better than me, that sometimes you have to resect a patch of the vein.
Was it
You
invaded
saw
in
that
the
in the
in
middle
pathology?
hepatic vein
Was it invaded in pathology?
No.
Okay, thank you.
Happy, eh?
Was not
invaded, eh?
necessary. So
Fantastic.
you're right. Oh, okay.
You
Go on.
want to comment also this, please?
I mean, it is not a failure of the R1 vascular if you resect partially a part of the hepatic vein. In our series, it happens often. But first of all, he did a double-sided R1 vascular. The middle hepatic vein was detached, so this was a full R1 vascular. This is a partial R1 vascular. At a certain point, you don't have to demonstrate anything. If you cannot detach it, it becomes risky. Resecting part of the vein is the advantage of the hepatic vein that gives also the mid solution, no? You can also resect partially, and most of the time you don't need the patch. So, as you did.
No, it was running future.
We have patched twice. So I think there is no contradiction. R1 vascular is possible when there is not infiltration, just contact. So this is the if you add it. Most of the time, you have the chance to, for the hepatic vein, most of the time. It's very rare. When it is unsuitable, most of the time, it is because the contact is so tight and so large that you may expect that there will be the sacrifice of the vein, and they have the collaterals, because the liver adapted to this stricture. In example, according to, it's not my experience, but it's also my experience of 20 years in Italy, but this was the one of Macucci previously. He never substituted the inferior vena cava, never. I can show you the picture, and we did the same. You just have to take time, but most of the time you do, like the hepatic vein, a partial resection.
I believe you.
No,
Just a question.
I have the picture.
Is the size of the metastasis influence in your technique? I mean, that is perfectly understandable for small metastasis, but for large one, with a large contact, relationship with the hepatic vein, do you still do that, or the size is important for you? No?
Paradoxically, we do the resection, the partial resection, when there is a big metastasis that has been shrinked after chemo, and the relationship with the vessel becomes tight for inflammatory reaction, and then with a tiny lesion like this, you cannot detach the tiny lesion. While naive metastasis, it was the experience before that we didn't do the neoadjuvant, even large, just compressing, 95% they can't be detached. They just push the tumor, the large metastasis.
Okay.
You convinced?
No, probably not.
Okay.
Of course I am.
Yeah. Yes. Nobody wants. You want to comment? No. Eduardo, nobody. Antonio, no. Okay.
Well, thank you. Thank you very much.
So may I call Fabio Procopio and Catherine Tett for the discussion?
Catherine is not here, I think.
Is not here? No. Some others.
There is no more discussion.
Okay.
I'm honored to be here. Thank you very much for the possibility to share my paper, and thank you, Professor Bismuth, and thank you, my mentor, Professor Torsilli. I talking about the application of the compression technique for anatomical liver resection in minimally access liver surgery. In resective fields, as well known, the anatomical liver resection is the best oncological treatment for hepatocellular carcinoma. The first suitable solution for defining liver segment in anatomical fashion has been proposed by Macucci with the dye injection technique. These techniques, more recently, has benefited by the ICG introduction obtained or positive stain area by direct injection of ICG in the portal pedicle, or the negative staining one when we clamp before the portal feeding the tumor, and then the ICG is injected by intravenously. But the problem is this technique has the same drawbacks related to the dye injection technique because we have no negligible rate of unsatisfactory staining area. So another solution is the technique proposed by Takasaki, the so-called Gleasonian pedicle approach, and we know it is very technically demanding and is associated to high risk to biliary vascular injuries. The evolution and the alternative was the technique proposed by my mentor, Professor Torsilli, the so-called compression technique, consisting in the finger compression of the pedicle feeding the tumor obtaining, and a transient ischemic area is easily to be detected and demarcated by electrocautery. More recently, we implementing this procedure injected by ICG. This is a procedure we compress with the finger the pedicle feeding in the tumor, and we had that ischemic area. And then under compression, the ICG is injected by intravenously by the anesthesiologist. In this case, the resection area become like no stain is more clearly to evident on the liver surface. This is the compression. We can see the pedicle before and under compression. We can see the resection area. Under the compression, the anesthesiologist injects intravenously the ICG, and the anatomical area become more clear and can be demarcated by electrocautery by the first assistant. And this is the resection area, and this is the cast surface with exposure of a right hepatic vein. In a minimally invasive surgery, of course, the anatomical liver resection is a very challenging procedure. The most common procedure is the Gleasonian approach, but as well reported, is a high risk of vascular barrier in injury. Otherwise, another technique is the injection technique with the same limitation of the puncture techniques, but we have higher complexity related to the minimally invasive setting. So, another approach is the hepatic vein approach. Is an effective technique, but is related to high risk of uncontrolled bleeding for pull-up injury to the veins or for direct injury on the vessels. So now we try, on the basis of our experience on the compression techniques, we try to transfer the technique from open to minimally invasive approach. So we start with our preliminary experience. We included patients with very non-located tumors, peripheral lesion, and with just one tumor-feeding pedicle visible at the preoperative imaging, and we exclude patients with vascular thrombosis and deep located tumors. And we start with the laparoscopic approach to become more confident to the procedure because we have the tactile feedback, and then we transfer the technique also in robotic approach, as this is a tumor location in our experience and post-placement. And we start with the laparoscopic approach. Like in open surgery, we start with the left side lesions. This is the first case with the lesion located in segment 2. We can see the pedicle before under clamping. We have the probe one surface and the opposite side with the grasper. This is the fluorescence images with the ICG injection, and then we can see no insidious area that is demarcated, and this is the cut surface with the stamp of the pedicle for segment 2. This is another case, is a segment 3 segmentectomy, is here ultrasound image with the compression before and under compression, and the under compression performed by the first operator, the first assistant, demarcate the resection area is clearly evident like a non-stained one, and below we can see the resection area and the stamp of the pedicle for segment 3, and then this is part of the left hepatic veins. After that, we try to adapt the same technique for right side lesion. This is a case of a lesion located in segment 5. And then we explore also the feasibility on the posterior superior lesions. This is a case of ACC located in segment 7. This is a 3D vertical cast with the resection area, tumor location, and the pedicle to be compressed. Now this is the compression. The patient has a chronic steatohepatitis, so we can see the discoloration of the liver. And under compression, the ICG was intravenously injected. And then anatomical area of the segment 7 was clear, evident, like a non-stained area. And during the first surgeon compressed the liver, the first assistant with the electrocautery demarcated the area on the liver surface. This is the pedicle compressed before, and this, we can see the right hepatic vein exposed on the cut surface. And then we transfer also in a robotic approach. We started the robotic program last year. This is a case of a huge ACC located in segment 7. This is a virtual cast with the right hepatic vein, with the compression point and the lesion in segment 7. This is intraparietal ultrasound. We can see the pedicle is compressed by his robotic instruments. And under the compression, in this case, the first operator can be done everything because we have 3 arms. This is the demarcation, and we can see the discoloration area here. The lesion is here. Is clearly evident on the liver surface. This is the final resection area, and this is the pedicle for segment 7. And here on the right, we can see the right hepatic vein fully exposed on the cut surface, meaning an anatomical resection of segment 7. So our results. We include 13 patients. The procedure failed in just 2 patients, both in laparoscopic and robotic approach, both for a lesion located in segment 7, probably because the pedicle was too deep to be compressed in an effective manner. This is the surgical procedure in details, 6 laparoscopic procedure and 5 robotic procedure. All procedures were air margin, 0, no complication, no conversion, and no relapse and local recurrence after median 30 months. So in conclusion, the ICG compression technique is safe for performing anatomical liver resection in the oncologic and adequate. This preliminary experience shows an encouraging applicability on ICG compression in laparoscopic and robotic secting. Of course, we hope for the study are needed to investigate its applicability and to standardize the procedure. Thank you very much for the attention.
So there is an open discussion. Nobody want? No.
That was a terrific presentation. I just wonder, a small technical question about the increased difficulty in patients with more fibrotic or cirrhotic livers, and how well you're able to achieve that same compression, or is it not an issue?
I don't understand. Please,
I'm
can you
sorry.
repeat, please, the question? The compression of the liver?
In patients with more fibrotic or cirrhotic livers, do you find that there are limitations to the ability to compress like you're describing, or is it technically not too difficult or different?
No, it's not so difficult to compress the liver. So, of course, the effective of the procedure depends on the stiffness or of the liver, but sometimes it can be a selection criteria for anatomical and non-anatomical liver resection, because if the liver is too hard, probably is not indicating anatomical resection, so we can plan an enucleation or a partial resection of ACC.
So technically makes it more difficult then?
Yeah. Okay. Is reversible, is not invasive. I suggest to start in open surgery to be confident in a procedure and then to transfer to in a minimal invasive setting. But I think it's not dangerous or not particularly difficult.
Thank you.
Thank you very much for the question.
So, any other question? Thank you very much.
Thank you, thank you.
Pardon. Okay, now I would like, for the young people are not compagnons, you can talk also. It will be nice to have a question from you also. Please be interested. This is a meeting, open meeting. Giuseppe Torre, please come. Role of surgery in patients waiting transplants for HCC.
Thank you very much. Merci beaucoup, Monsieur Bismuth. Thank you very much, Guido, for the kind invitation. I also am not compagnon, but I'm the guest. So I have to speak the role of surgeon and patient waiting list for transplantation. I want to thanks, first of all, Guido that participated to this publication in Springer, Italian publication concerning ACC. Treatment of ACC during old or before old is a challenge because considering downstaging procedure and the treatment of ACC during the waiting list. So surgery in potential candidate for transplantation, there are some concepts to stress: selection tool, bridge transplantation, salvage strategy, downstaging strategy. And there are some technical key points in candidate for transplantation. The surgery can avoid prolonged pringle clampage, avoid, when it's possible, cholecystectomy, avoid open surgery when possible, avoid hemostatic agents, avoid inferior vena cava exposure, early drain ablation if it's possible, anterior resection cause some major visceral adherence. So minimal invasive approach is more demanding for some reason: no portosystemic shunt interruption, no large liver mobilization, no contact with atmospheric area. For example, this is a resection of an anterior approach segment of the liver, segment 4. This is a good indication before transplantation, like downstaging or like bridge procedure. But the problem is this is an anterior segment. At the time of transplantation, you can find many adhesions of this segment with the surrounding tissue, duodenal, stomach, colon, and the transplantation may become difficult to perform. And Olivier Soubran showed also that the adhesion, when you perform the laparoscopic or minimally invasive approach, can be, we have to promote the minimally invasive approach to reduce adhesion. Also, the surgery move to child PAG B cirrhosis. This is a multicentric study. And also, Guido showed that we can treat patient child Chi with surgery also before transplantation. For selection tool, we have to consider that some G3 patient may have a high risk of recurrence after all, so we operate after we have to decide quickly what to do, or quickly to surgery, to transplantation, or is not good to propose transplantation with this patient. This is a patient with a G3 little ACC that we operate, and after we have to decide if to transplant or not this patient. This is a little laparoscopic ablation of this tumor. Bridge is a concept really important because from the beginning of the waiting list to transplantation, the ACC growth, there are many treatments, TACE, ethanol injection, radiofrequency ablation, liver resection, or radioembolization. Every tumor board have the policy, flow chart. We have our flow chart in Rome, that concern from the experience of the center of the guideline of the society. This is a resection of a patient that was resected of the left lobe, an ACC of the left lobe, and recurrence in segment 8. And we decide to treat this patient with transplantation also of the tumor of the right lobe. And you can show that there are many adhesions, even if it was treated of minimal invasive approach of the left lobe. The cirrhotic liver, we mobilize the liver and we remove the tumor of the posterior segment. The problem was that there was portal hypertension, but with the robotic approach, we could control the portocaval shunt that you can show in this film. And this device can control this shunt and coagulate this shunt without major problem. Shunt between the liver and the diaphragm, between the liver and the tissue around the right lobe. And the salvage strategy is also an important concept because there is operate the patient, waiting the recurrence, after the recurrence decide. At the beginning of the 2000, there was a querelle in Paris between the two important equipes with the strategy of this patient, which kind of treatment was the best, but René Adam with this study and Monsieur Bismuth show, and I agree with him that the transplantation is the best treatment of this patient. And I remember when Professor Bismuth came in Rome and showed me that the patient in this study is different of the patient in the other study. I show a picture, explain in my bureau this conclusion. And we are not too much liver to transplant, so more and more we utilize resection before transplantation. And we are our experience in Italy of the transplant salvage transplantation. This case was a patient that was first submitted to the left lobe resection for ACC, ethanol intake of alcohol was not possible to transplant at the time of the first ACC, and so we decided to resect the left lobe and wait after 2 years of observation, recurrence of the right lobe, and we arrived to transplantation. You can show that at the moment of transplantation, there are no major adhesion between the liver and the surrounding tissue. And the last point is the downstaging strategy, and we all know that know the Milano criteria is possible to go in this criteria, but the BCLC tried to move with on the left side to put the intermediate stage and advanced stage in transplantation. So we utilize many instruments to reduce the disease, the FCC. So this trial of Mazzaferro showed this is the good results of downstage patients that go to transplantation. And also this is a case of a patient with a disease on the right lobe and left lobe. Then we decide to control with minimal invasive approach on the left lobe and radioembolization on the right lobe. The alpha fetoprotein that was at the beginnings of more than 1,000 arrived to 45 at least in the moment of transplantation. And so this is our strategy of downstaging with many times that utilize radioembolization with E390. Also the ALPS we consider before transplantation, in our case of 42 cases of patients with huge ACC that arrived to be resected with good results in the post-operative field. And this patient many times have macrovascular invasion, and we have a surprise that one patient, even if the volume future liver remnant was okay, developed a post-operative liver failure. Post-operative liver failure is a very difficult to treat, and we try to put auxiliary transplantation in this case. You can show on the left part the remnant left liver after ALPS, and on the right part a little graft to try to reduce, to control this disease. So also the last slide is this. I want to thank Vincenzo Mazzaferro for this study that tried to prioritize the patient according to the treatment that received this patient. In conclusion, surgery liver transplantation setting is more demanding, can be considered before listing, during waiting list period, or as a downstaging scenario. Surgery can be associated with other intervention procedure of bridging, downstaging with encouraging results. Surgery have to be considered more and more laparoscopic or robotic. Thank you.
Thank you for discussing this paper. Is Hugo Pinto Marques.
Thank you very much for this nice presentation. As you know, of course, the problem of organ shortage is one of the things that make us have this discussion and think about using resection, for example, as a bridge to transplantation. One of the things I wanted to ask is actually, we know we had a lot of polemics, especially about resection and transplantation, when we compare the results of the Paul Bruce and the Bourgeon group. This is an ancient discussion, and we know at that time that one of the reasons between the different results of the two groups, one of them was methodological and about inclusion of patients in the transplantation group, whether legitimately or not, and the other one was the percentage of minimally invasive patients in the HCC resection group before transplantation that apparently led to better results. So my first question is if you think that the fact that we are doing more and more minimally invasive resection is influencing the results toward better results after transplantation. And the second thing is a provocation. I think if you use ALPS for resection, you are going to induce much more adhesions in a liver transplantation. Do you think this is going to worsen the results or not? Thank you.
Thank you, Hugo, for the two questions. The first one with minimally invasive approach, I agree with you that the paradigm change with minimally invasive approach on the ACC actually, because the transplantation more easy. And you observe that, in our 42 patients that have ALPS, only one was scheduled for transplantation, because I agree with you, many adhesions, pedicule difficult to dissect, and so I agree is a frontier of this surgery.
Okay, I'm going to open Sylvia, please.
Congrats on your presentation. I'm Sylvia from Lisbon. We are actually doing more and more resections of HCC in cirrhotic patients by robotic approach. And we have seen that with the robotic approach, we have less ascites in post-op than in open approach. Do you have the same experience? And do you know why this happened? It's because the mobilization, it's because we perform more Pringle maneuver actually with the robotic surgery, but we have less dysfunction in post-op.
Yes, I agree with you. You observed this concept was stressed by Gianmauro Berardi when shown with the Japanese in the study of child B patient treated. And I agree, less liver mobilization, less portocaval shunt interrupted, maybe less pedicule Pringle maneuver, many factors that the results of ascites are much better. ACC, but also in liver mets, in all the laparoscopic surgery, not only in the liver, also in the colonic and other pathology.
Especially in cirrhotic livers.
Especially in cirrhotic, of course. Mobilization, portocaval shunt, and many things. Thank you.
Another question.
Yeah?
It's about downstaging. Now we have more and more drugs like atezolizumab. Do you think that atezolizumab will bring more patients to resection than to other kind of downstage local therapy like chemoembolization or microwaves?
I think yes, but not alone. I think atezolizumab and other immunotherapy, not alone, but combined with radioembolization or chemoembolization, radioembolization in particular. Really strong procedure that is not demonstrated, but maybe that atezolizumab or the immunotherapy are more with good results in patients that perform before radioembolization.
Yes.
Eduardo, please.
Very nice, your lecture. I enjoyed it very much, very complete. My question is, which is your opinion about radiofrequency in the cases that is indicated to maintain this patient active in waiting list?
That's a good question. We don't know radiofrequency for a surgical procedure, and our radiologists perform radioembolization with the recurrence of DCC in the posterior segment difficult, so we utilize radioembolization, radioablation more and more. And also radioablation have some improvement in the last year, difficult need. So yes, we utilize, but is in the radiology unit, not in the block.
No questions from the more... please, René.
Just congratulations. Just a comment concerning the debate about resection transplantation. I will not go deeper in this debate, but it seems to me very important for the message we give to our patient. What we know is that, of course, transplantation is doing much better on the long term, disease-free survival, and so on. But anyway, what the message we give most often to our patient is, don't worry, we resect your tumor, and if you recur, we will transplant. But what we know factually is that in 50% of the case, this will not be possible. And so our message should be a little bit different, with a nuance, to say to the patient, we are obliged to resect you because we have no sufficient donor to transplant you, but know that it is not 100% the opportunity to transplant you in case of recurrence. And in the case of possibility of living donor transplantation, this may change a little bit the opinion of the patient and of the family. And so we should be honest in the message we give to our patient. I don't know if you agree on this.
Thank you, René, for this question. Is my policy in Rome last year, I performed 70 liver transplantation, not huge number, but important number. When it's possible, I resect, and I don't speak of transplantation at the first line. When there is the recurrence, when there is decompensated cirrhosis, I move to transplantation, because I agree with you, it's not honest to propose liver resection when transplantation has better results. And so I don't propose like first line, because I can't.
Okay, just a moment. Ricardo, please. And after, okay, please, Valerio.
It's the same kind of reflection, more ethical reflection. The problem is that we share all the same organs, and if every centers don't do the same, there's a problem, because we have the same policy of salvage transplantation, so we operate those patients, but if our neighbors, transplant centers, don't operate the patients and they list systematically all the patients, there is inequality of treatment offered to our patients. So our patients that we operate, because we think that for the population it's better, for the patient, of course, it's not better. For the patient, it's better to be transplanted. So there is an inequality. So there should be probably a political decision or a general decision that everybody does the same.
I agree with you. This is a political decision, not surgical decision. Everybody knows the different Établissement Français de Grefte and Italian Center of Transplantation. They have to correct, to change this history, I think.
What do you think? Congratulations on your presentation. What do you think about resection as a tool to select patients to direct transplantation? We analyzed our series and we applied several classification systems in high risk and low risk. We became with a classification that give our patients high risk 13% 5-year overall survival and not, low risk 98% of survival. What we are doing now is applying after resection and applying the classification, we are transplanting upfront the patients with high risk and we are monitoring the patients with low risk. There are already groups like Lisbon who go doing the genetic panel, we are doing the immunological one, and we are trying to figure, before resecting the patients, is to know what are the patients that are going to benefit more with a transplant and the patients that will go well with a resection. What do you think about it?
I think that when we try to resect this patient to have the specimen and to decide if it's aggressive, not aggressive, satellite node, G-trap patient. In this patient, we have not proposed quickly a transplantation, but radioembolization to control the disease. We speak in the meeting with the pathologists, some drug, immunologic or atezobeva in this category of the patient. And we observe test of time, and after we decide if can we do a transplantation or not candidate for transplantation.
So you are not doing upfront liver transplantation after resection?
No.
Okay.
More questions from the Professor Bismuth.
Often, HCC in cirrhotic patient, there are two diseases. One is the tumor, two is the cirrhotic patient. Resection treat only one. And transplantation both. Unfortunately, we cannot offer transplantation to all patients with HCC. And I may say also, unfortunately, HCC on child A cirrhotic, you do resection. And you give the better treatment of HCC in child B or C.
This is a reflection. We finished with this. Do you want to comment this?
No, this is
Thank you, Professor Ettore.
Honored comment.
Okay. I think that Professor Dong is not coming, but I would like to, Guido, I decided to say thank you very much for organizing this meeting at the end of the session and not at the beginning. And it's a pleasure to be here. And thank you very much for organizing this fantastic meeting. So, what you are going to do, Professor Dong, are you doing this? No, Dong is not coming.
Okay. We tried to contact him since yesterday night and send a link for give the presentation, but he never answered. So
not in prison? No.
I don't think so, but I don't know which was the emergency meeting that he had with the government. You know, in China, you may never know what is going on.
What's a joke? That's a responsibility for
so
me.
Nowadays, we anticipate the lunch break, and probably we could also anticipate the beginning of the session and finish earlier.
Sorry?
And I would like to ask to all the Compagnons to confirm their presence tonight to the secretary, not to me, to secretary. Because if you confirm to me, it will be a disaster for you. I will forget for sure the names and whatever. Sorry.
So Guido, you can begin the session 2 o'clock. What do you think? Anticipate 35 minutes the afternoon session.
Yeah.
Okay, we
It
begin
depends
at 2 o'clock.
He will decide.
After lunch.
Professor Bismuth will decide.
Professor Bismuth?
Will decide.
Professor Bismuth have already decided that we begin at 2 o'clock afternoon.
Well, good afternoon. We'll start the final session. I'm John Isaac from the UK. Catherine Tay is not here. We have Lawrence. Catherine Tay.
An avatar of Catherine Tay.
Also known as Lawrence Sheesh. So we will have the program start. For every case, we'll have a discussant, as this morning's, just like this morning. We'll have the discussant continue after the presentation, and then we'll open to the floor for discussion. Okay, so we'll call upon Valerio to give the first talk, and that's a rectal tumor with synchronous liver mets with chatitude.
So thank you very much. First of all, thank you to Monsieur Bismuth, to Guido Torzilli, to Ugo for taking my presentation to present to the Compagnons. So it's a study, the RECILIMET, which is the acronym for rectal cancer surgery with synchronous liver metastasis. What resection strategy should we perform? So it's first, we know that rectal cancer, 20% of patients have synchronous liver metastasis, and the guidelines, the published guidelines from the ESMO and from the ASCO still say the scheme of chemotherapy followed by radiotherapy, rectal surgery, and at the end, liver surgery. And of course, the aim is to have a complete resection to increase the overall survival. And already 15 years ago, the Compagnons from Geneva proposed the inverted strategy of liver-first strategy with very interesting results. And so nowadays we have three types of strategies available to face those patients. Rectum-first strategies, where we have to be assured to have a symptom control, but the problem is that the morbidity and the ileostomy may render more difficult the resection of metastases that may become unresectable during the waiting period, and we have the problem of hepatotoxicity. Then the inverted strategy, where we begin with liver surgery, there is no problem of, or less problem of missing metastasis, and the criticism of the colorectal teams is sometimes that rectal surgery may be more difficult because of more adherence and more difficult mobilization of the colon. And then the synchronous approach, of course, there's an advantage of length of stay in the hospitals, of costs, but of course is only limited to a very small amount of patients where the surgical complexity is low. So the aim of our study was to verify in those three types of strategies what is the complete resection rate and a secondary endpoints if the liver-first strategy does hamper rectal surgery, and so is there more anastomotic leak? Is rectal intraoperative and postoperative outcomes the same if they underwent liver surgery before and not, and if the morbidity and the mortality of rectal surgery is increased with the liver-first strategy. And so we underwent, the work is done by an assistant who, for his end of residency, made a work between our hospital in Brussels, Erasmus Hospital, and the University of Padova, but the colorectal center is not the HPB center of Padova, a 10-year experience, 2010-2019, and where we selected the patients who underwent the three strategies. The inclusion criteria roughly was all medium or low rectal cancer which needed radiotherapy, so T3, T4, and plus tumors with liver-only liver metastasis, so no pulmonary metastasis and no other locations, and that the resection was planned with a clear strategy. So the exclusion criteria was all high rectal cancer, all the transanal approaches, and the presence of other metastases. So roughly from 800 patients in both centers who underwent rectal cancer surgery, we end up in the Italian center with 16 patients who underwent, who were included in the study, and in the Belgian center, 29 patients who were distributed in this way. We see that we have 13 patients who underwent rectum first strategy, 20 patients who underwent liver first strategies. They were all in the Belgian center, and 12 patients who had a synchronous approach. And so we see that the liver first strategy were all done in a liver first interval approach. It means that they underwent the liver surgery at the end of long course radiotherapy. Now, until a couple of years, we don't do any more long course radiotherapy, but short course. But all in those patients were all with long course radiotherapy, and the liver first strategy was done at the end of irradiation. So looking on the results, so the three groups were roughly similar, just the liver first patients were a little bit fatter than the other, so a higher BMI, statistically significant, and the other factors were all similar. Concerning the tumor characteristics, also there, no statistical difference. We see that we had quite a high number of metastases, a median number of 5 metastases, and 62% in the rectum first and 75% in the liver first strategy were bilobar locations. So concerning the results, complete resection rate was, it means that the primary tumor and all the liver metastases were finally all resected, was of 85% in the liver first and in the synchronous approach, and of 62% in the rectum first strategy, but statistically no statistical difference, even though there might be a tendency for a better results for the liver first strategies, and so the same numbers as the first publication of the Geneva publications. Concerning the survival, same survival for the three groups. So no statistical difference in survival, and of course, patients who did not achieve a complete resection rate had a statistical worse long-term survival compared to patients who reached a complete resection rate, which is quite logical. And concerning the secondary endpoint, so does the liver first strategy cause a more difficult rectal cancer surgery? So we had a quite high anastomotic rate, but they were all grade 1 fistula, so no treatment needed, and were all, I think, almost all asymptomatic fistula, which were visualized by enema at the control before closure of the ileostomy. And so the three groups had roughly the same, so no statistical difference between the three groups. And concerning the operating time and the complications, also there, similar results between the rectum first and the liver first strategy, except for length of stay after rectal cancer surgery, where there was 1 day difference in the liver first strategies, very probably because of different habits in the postoperative follow-up of those patients. Concerning the overall operating time, we are talking only of the rectal cancer surgery, so a shorter total operative time in the synchronous approach, of course, compared to the rectum first and liver first when we add the two times of rectal and liver surgery, so there was a difference, and also in length of stay, the cumulative length of stay of liver and rectal surgery for the rectum first and liver first groups, and shorter, of course, for the synchronous approach. For the rest, no difference. And concerning the oncological resection of the rectal cancer, also no difference between the groups. Same number of retrieved lymph nodes, and say roughly the same R1 resection of those cancer. The follow-up was also quite similar. No operative mortality, and long-term complications were the same in the three groups. Long-term complications roughly are éventration, I don't remember the name, or parastomal incisional hernias. So, of course, this is a very small study, retrospective, very small sample size, and of course very dependent on local practice, but we had a very strict inclusion criteria and a long follow-up and a validated protocol by both ethical committees. So in conclusion, we didn't see any significant difference in complete resection rate between liver first and rectum first strategy, even though we saw a tendency for a better results for liver first strategy, and concerning the secondary endpoint, we didn't see any factor that shows a more difficult approach of rectal surgery after a liver first approach. So I was wondering if we could do a companion selection of those patients, and if centers want to participate and retrieve those patients. We don't have normally a lot of patients per center, so it was a question if it could be interesting for our centers to participate to a common retrospective study. Thank you very much for your attention.
Okay, we'll have the discussion. Yeah, Guido Costa.
Thank you. Thank you, Dr. Lucidi, for your presentation and for your study of a current topic. I have just two questions. One of them is on the strategy selection criteria of those patients. You said that one group of the patient did all the liver first surgeries, and the other center did almost all the simultaneous resection. And you showed us that there is a non-statistical difference, but there is a difference in the number of liver mets resected. So just wondering if you can comment a little bit on how these two groups selected the patient for the two operations.
So of course, this is a big limitation of this study, because we compared the attitude of a more hepatobiliary center with a very good collaboration with our rectal cancer surgery. So all our decisions of resection of liver first strategy was on a multidisciplinary setting with oncologists, rectal cancer surgeons, and liver surgeons together. And the selection is for multinodular, mostly bilobar tumors. We try to favorize liver first strategy at the end of radiotherapy, chemotherapy and radiotherapy, of course. And in the Italian center, it was, I think, I don't know them, so, but I think it's mostly a colorectal center, so which is not the hepatobiliary center of the same university, and so quite a different approach, because they favorize a simultaneous resection or a rectum first resection. So the selection, I think it's also done in a multidisciplinary setting, but of course with a different decisions.
a second comment, yes, on your primary endpoint. You showed us that you had a lower complete resection rates on rectal first patients. So if you can comment what happened to those patients that did not reach a complete resection after the rectal surgery, and if you have any information on those patients who did a liver first and did not have a complete, because if I understood it well, you started selecting patients based on the rectal resection, considering the patient that did receive rectal resection.
Yes,
okay.
yes. So, yes, we started from rectal resection, but we so in the Belgian cohort of patients, roughly we took all rectal cancer surgeons. So it's a limited amount of patients because had to have radiotherapy, had to have liver-only tumors, and of course resectable. So non-resectable or marginally resectable were not included, and for the selection of the Italian cohort of patients, I think they took all patients who underwent rectal surgery and liver surgeons. So probably there is an amount of patients who is not picked in the study. But normally, this was a selection based at the time of rectal diagnosis with liver metastasis. So, and this is where the time where we included them. And so the patients who were not resectable at the beginning were not included in, for liver not resectable were not included. For the questions, what became the patients who were not completely resected for, so the patients who had a liver first strategy is the patients who recurred very fast after the liver surgery. We have two patients who had resection and a thermal ablation and had a recurrency at the border of the thermal ablation, which I also don't like Guido. And so those have been classified as non-complete resection.
Yes, this study is very interesting, and we have to state that all these patients has a synchronous disease, and all these patients need chemotherapy before the treatment. And in different series, more than 80% of the patients respond only the rectal of the liver just with chemotherapy. Maybe most of the cases, you don't need radiotherapy, because when you apply radiotherapy, you have to stop with the huge chemotherapy. Second one, when we speak about rectum surgery, we have to speak about specialists, because middle or lower rectal surgery is just for specialists. It's not for general surgery. The same for complex liver resection. So one of the limitations when you're speaking about synchronous disease is that you need two specialists if you want to have good results, as good specialists in liver and as good specialists in colorectal liver surgery. The third comment is that when you are selecting, you can have a huge hepatic disease. In this case, maybe you have to apply the liver first. And maybe you also can apply, we have in 10 years, 53 patients selected for simultaneous rectum and liver resection, but we operate with specialists in colorectal, and all these patients had been discussed in a multidisciplinary way. So you say that you have two patients that they can't complete the rectal resection, or that means that the margin was positive.
That the margin was positive.
The margin was positive, but the surgery was complete. So I think that we have to think in that. Sometimes the complex surgery is the rectal, but and sometimes the liver is easy, but to drive a plane with 4 turbines, that is middle rectal and lower rectal, is not the same that high rectal disease that is a plane just with 1 engine. So you need very good specialists. It's the same for liver.
I totally agree with you. So in our team, the rectal surgery is done by the colorectal surgeons specialized for this, and they do, so all resections are done by laparoscopy or robotic, and so it's 2 different teams who operate those patients. So we, as HPB surgeons, we don't operate those rectums, so it's 2 teams. It's also probably the reason why we do very seldom synchronous approach for rectal surgery. So I totally agree with you. It's 2 different specialists, and we take the decisions together. So it's very important to work together. And some patients who underwent rectum first surgery didn't achieve final hepatectomy because of evolution between the waiting point. And all patients had chemotherapy. And you were talking, your question was on radiotherapy. All those patients needed radiotherapy because it were only T3 and T4 and plus low rectal cancer. So radiotherapy is advised for those patients.
Okay, the comment of Eduardo shows that it's a debate from a long time, and the problem is that there is a lot of factors, and we have to discuss case by case, and first you have to see if they respond to chemotherapy, and after this chemotherapy, sometimes there is a lot of change because there is nothing in the rectum, and it depends also of the discussion about what is the healer. I mean, if it's the rectum, it is the liver, and we can say that this liver first strategy was really convincing a lot of years ago, because rectal cancer surgery was really morbid. It has changed. Sometimes they do just watch. Sometimes there is a laparoscopy, robotic, and it's changing also. So I don't think that such studies could help, because it's so heterogeneous. And I see young surgeons, I think it's confusing for them, because, well, we don't know what to do. And I think that case by case, because you have 12 and 30 patients in group, it's very small groups, and they are not the same patient, you know that. So I think that I agree, it depends on a lot of factors, case by case.
You know, as Angelita Abrangama from San Pablo has demonstrated, 15% of the patients that receive chemotherapy in order to reduce the liver disease have not disease in the rectum when they explore. So if you start with the liver and you study, and maybe you have a huge response to chemotherapy, maybe sometimes you don't need to operate on the rectum.
That's exactly what I said. Okay, thank you. Another comment, question? We can move on, and it's a real pleasure for me to introduce Guido. Speaking of what? Parenchyma sparing surgery between stage hepatectomy and liver transplant. What a surprise.
Yes, because, you know, I have already ready this presentation. I have to take care of all these patients. I cannot introduce a new argument. So, but I think there is something new also here. At first, thank you very much, not for the invitation, because it's but for the consideration. So, at first, the background of the talk, and every one of you agree, the target is the R0 world. And this is a review paper by Petrovsky and Pierre Alain that published on Lancet Gastroenterology and Hepatology, and it was shown the panel of R0 resection, in which there were many figures representing the multiple bilobar in the staged procedure. The margin is one of the issues that has found some debate in the years, and still now is an object of debate with the introduction of the R1 vascular, and most of you agree to the fact that R1 parenchymal is something to be cancelled. But in the fact, in the history, if you see, the surgeon has always been attracted by the tumor edge from more than 1 centimeter. It was an irresistible temptation to expose the tumor, and there was the 1 millimeter. 1 millimeter is difficult to be considered and measured. And also the literature was always more and more looking at that. Probably it would have not been really a disaster like in this case, but there could be some room for long-term survival, and René showed us that by necessity, the results were everything but not bad, because they were almost similar in terms of long-term survival to R1. And this was the R1 totally considered. This was a survey that we did among several centers in the world, and by necessity, more than 50% did agree about the use of the exposure. And this paper from Nick Vautet, that is going to come, he couldn't because his flight was cancelled yesterday, so now he's going to arrive in Milano, I guess. He was showing that, look, less than 1 millimeter, the recurrence rate was similar to the other. These were papers in which there was not a distinction, but anyway, we can say that by necessity could be also accepted the R1 parenchymal, still not, if not green, it is at least yellow. But as we discussed, there is also this fact, this is a different pattern, and the hypothesis I disclosed many times these days, different anatomical part, so different concept of recurrence, and the possibility to make the detachment of the tumor from the veins and the Glisonian pedicle. And as it was mentioned, the anatomy induced us to be optimistic in this sense with the Lennec capsule, which was not discovered by us, but we took profit of this fact, according to the paper of Sugioka. Then we started detaching the tumor from the hepatic vein and the Glisonian pedicle, and this was the first paper that was showing our series of one-stage hepatectomy, in which the reviewer, to allow me to publish, asked me to cancel the overall survival. I don't know why, but I couldn't refrain to be accepted this paper to come out in the literature, and then I accepted that. But we did the paper that was published later on with the larger series, 727 areas, 226 patients, and the R0, R1 vascular were behaving almost equally on a long-term series in intention to treat disease. And if we focus on the hepatic vein at the caval confluence, as I was mentioning, look, the partial resection was in 1/3 of the patient. Half of them were just detached, and a few of them were patched. You may ask, what about the other? I will explain later on. Then we can say that R1 vascular, at least in our perspective, is fully acceptable in terms of oncological suitability. If you talk about the R1 vascular, when it doesn't work in the case in which you cannot save the vessel, the liver provide the solution itself. Look, this patient with the 3 huge tumor, the one here is in contact with the right inferior here, and it was invading the middle hepatic vein. Then we have to amputate the vessel here and detach here. These are the resection areas. And at the end, there are the collateral circulation in this case that can be confirmed intraoperatively. This is the right inferior, and there was a collateral circulation with the middle hepatic vein. We have to divide the middle hepatic vein here to keep the collateral in between the right inferior and the left, and at the end, this was the collateral confirmed. This is the point in which we have to divide the vessel almost into the tumor. And this is the results. This is the right inferior. This is a tunnel. There was a detachment with the hilar plaque. There is only the left hepatic vein here, and the middle and the right were divided. And partially the inferior vena cava was sutured by resection. And there was another R1 vascular on the left side with the left hepatic vein. Now, in this way, you can do conservative surgery. We may say not really a minimal resection, but with sacrifice of the parenchyma, keeping the scaffold of the liver in almost all the patients. And if you assemble all this kind of approach, you can obtain good results. Moreover, because nowadays you can estimate, even in front of disease that demand a very complex 3D resection, you can estimate precisely the liver remnant, which is a big advantage, and has allowed us to push further our resection amount. Then, in front of a case like this, the rules are recognize the cluster, identify the deeper lesion in contact with the vessel, and those at the periphery of the area. Once you have done that, cluster compass points, you figure your resection area, and you carry out the resection, leaving, in this sense, a slice of liver. If you look this liver after 3-4 months, it will be very big, completely recovered. And so you spare a big amount of organ, because with the in and outflow perfectly done, and the biliary drainage too, believe me, it's very nice, and there are several operations that you can introduce in this modality. We say parenchyma sparing major hepatectomy, and this is one of the main criticized for us, the reproducibility. This is a case of huge involvement. This is the same after chemo. This is the liver cast. And these are the area drawn. And this is the resection. And this is the author, not me. So it can be transmitted. This is an operation done by us. And these are 2 operations. This is Dr. Sanket Mehta. He stayed 3 months with us. And Ramiro Fernandez, he has never been with us in Peru, but he's following our attitude. Then it can be repeatable. And the comparison, I just want to recall that in that paper, anyway, R1 in most of the report is not rare, especially when you are facing with a high rate of metastatic disease bilobally, and most of the time, even in the left margin, you have to expose the tumor, and the mortality is not negligible. We did the comparison, and the comparison was showing that we had a better short-term outcome, and the survival or intention to treat is in favor of the parenchyma sparing, because we don't have the drop out of the disease. We were challenged in this paper by the Italian Registry of Alps, and there was not the same complexity in favor of the Alps group, less complexity, 1 to 2 the margin. Safety was in favor of the 1 stage. And the long-term results in terms of outcome and disease-free were similar. And also, if you look at the recurrence-free survival, comparing the two stages and the one stage, they are equal. The salvageability is in favor of the major, the parenchyma sparing. This is a paper from Nick Vautet, showing that if you do a parenchyma sparing, you have a more chance of repeat hepatectomy, and even if you do advanced parenchyma sparing, like in this case, same situation of the sliced liver, with this dissection plan, is another patient similar to the previous one. And at the end, this patient was reoperated twice. Anyway, the 66% of the liver-only liver recurrence in our series could be re-resected. And another criticism, in any case, R2 surgery, this is a nice paper that has been already accepted to the transplanted patient, 64% of them are undetected CLM in the liver that was removed. Then the transplant has a big rationality, also because of the good results once you are within the Oslo score, the Fong score, the SECA2, in terms of overall survival. But if you are out of the score, the outcome is a little bit worse. Of course, the disease has changed its behavior, more lung recurrence which are indolent. So there is a lot of rational transplant, but the problem is, up to now at least, the transplant is referred to, as also René said, to a minority of well-selected patients, and I agree. It is, of course, there is the value of the organ to be implanted, and the donor also that determine this strict selection criteria. And surgery, I may say, that Colette is patient among those who are considered resectable, but resectability is a very vaguely determined situation, so it is very difficult to classify who are. Anyway, we operate the patient within the remaining 98% of patients with metastasis. So the less, we cannot select the blue eyes, the blonde hair, and the tall guys. And this, furthermore, there is even room of attempt with surgery to go towards the less favorable patient, even those with progressive disease, given the safety of a treatment, may have a benefit in survival, and with the inverse probability weighting, which will be a discussion between Gina and Dr. Famularo is the author of this paper about the machine learning and artificial intelligence. We saw that it was confirmed, a larger number of theoretical number of patients was confirmed this attitude of having anyway a benefit from surgery. Then concluding, we may say that our approach nowadays has had further confirmation. This was a very nice because it was very pleased with us. Sky Mayo on surgery commented the transversal hepatectomy about this kind of procedure. And in the future, I may surprise you, but if I see something that is fascinating before my retirement, it's this. And sorry, but no, just this.
Okay.
The printed liver.
The printed liver.
It may be with a transplant. At this point, probably I will have to surrender. Thank you very much.
So who's our discussion? Is he here? Fernando Alvarez, is he here? Yeah. We'll have a discussion now. Fernando, yeah.
Thank you very much. Well, Professor Torsili, great talk. I am a big fan. Okay, so first I would like to congratulate you and your team, of course. Yeah. And your team, of course, for the great contribution you have done in the last 15 or 20 years in the not only the technical aspect and advancements of liver surgery, but also our understanding of tumor biology in liver metastasis. So that being said, I would like to focus the discussion on the most controversial topic within enhanced one-stage liver surgery or parenchyma and sparring, which is R1 vascular resection. So I visited you in 2016, and I could witness how rigorous and meticulous you are in collecting data. So I believe what you have published, and in my own experience, since I've been doing R1 vascular resections, I could corroborate your results. But you published in 2018 a survey, a worldwide survey, in 270 surgeons from 51 countries, and despite half believed that R1 vascular was equally safe as R0 parenchyma, only 10% used it in a routine basis and 27% as per necessity. So still, we don't have that much acceptance as we would like to. So probably before you answer my question is how you could explain that. Is it the technical difficulties? Is the difficulty in breaking a dogma that we have been inseminated since a long time ago? And probably it could be, if the chairman thinks it's appropriate, we could update that survey, because we have nowadays here the Compagnons from all over the world, and we could have more updated data before you answer. So, and the other question is regarding R1 vascular. Did you find a difference in between R1 vascular in the Gleasonian pedicle and in the hepatic veins regarding recurrent survival? And is it equally safe, or you feel equally comfortable doing an R1 vascular in a patient that didn't receive preoperative chemotherapy and in one that received preoperative chemotherapy? Thank you.
I didn't propose the question. No,
but you're ready for the answer.
We are not discussing. But I am open to any question. Concerning the fact that 10% in 2017, it was 2 years later. It's not just detaching the tumor, it's also a concept of different way of dividing the organ and figuring the surgery, so it takes time, I think, and it takes also a decision or not. And I may agree that in the, I mean, for robotic surgery, I asked one of my staff to do it initially, because I feel a reluctancy to change my mind. So changing the mind at a certain age in a position of leaders, it's difficult. I cannot. I mean, the discussion is we don't have to be dogmatic against. And I saw that day by day. There was Oscar today that showed a fantastic operation in fully R1 vascular. As for the difference between Gleasonian pedicle and hepatic vein, it seems we have new results recently. There is one of my staff that is investigating these results, because now we have a big series, and it seems surprisingly that there is no difference, and it may behave better the Gleasonian pedicle. I may confess that I was expecting the other, but for the other, most of the time, we de facto excluded those who had some of them were not really detachment, but partial resection. So it's a salvage of, while for the Gleasonian are only the real detachment, because the other were the amputation. So probably in this sense, you could explain the same results.
The question about chemotherapy, you're comfortable, but the question was, would you only do it after?
Yes, yeah. Yes. The chemo nowadays, in our series, the entire series is 85% of the patients receive chemo. Most of the time, the patients are not undergoing neoadjuvant, but they had insisted chemotherapy because we are judged unresectable. Not only by multidisciplinary barrier surgeon. Most of the time, this is a bad habit of the oncologists in many hospitals. They decide by themselves that is not resectable, just based on the number of the lesion. And sometimes, you remember sometimes also 5, 6, 7, 8 lesion. It means unresectability still now for some oncologists. So the majority have the chemo. As I mentioned before, once you have a big shrinkage, paradoxically, despite a small lesion, you have to, it's like if the tumor is gripped. And it depends also on the kind of growth pattern, replacement or displacement, and replacement is the one that is more difficult to manage and include and determine the higher frequency of vessel invasion.
A quick comment and 2 questions.
And then Oscar, and then Pierre Clavier.
Vas-y, Romain.
All right.
Oh, so the comment is that I think Guido should be congratulated to having been able to spread a technique which was considered as totally anecdotal. How many times I have heard, oh, this is only done by Guido Torzilli. What you demonstrate clearly in these 15 past years is that not only you have spread this into your team, but also you have spread it into other teams with more and more factual, I would say, convincing results. So congratulations for that. Now 2 questions. The first one is, do you make any difference between, I would say, R1 vascular on the hepatic vein and R1 vascular on the portal vein? Because this could be a little bit different. And my second question is provocative. By seeing all you are doing, it seems that the number of metastases is not anymore a problem for you, even 20, 30, and so on. So my question to you is, what do you think is today a good indication of liver transplantation?
So Guido, have you answered the first question about hepatic vein and I think that's, you said it's no difference.
I said the data are showing that there are no difference, but I think also it's due to the fact that the real contact of the Glisonian pedicle results in amputation, so we don't see the real infiltration. We see
so the second question is liver transplant. We don't need it anymore, basically, from René.
No, I think that the liver transplant is, I am fighting with the management of this hospital because I want to see the possibility to start a transplant oncology program. Not for me, for myself, because it will take bureaucracy and whatever 10 years. So I am 60, so I finished. So I trust. I think it's a nice option. For now, is dedicated to a little part of. I asked to Paldac to do a study with us, with our patient, because I had one of the staff that visited us and they said, we don't even transplant this patient that you operate. And then we have to do a real case match for the really otherwise unresectable. I don't say that we are doing the miracle, but in example, double R1 vascular, most of the time, multiple disease, is considered unresectable. For us, it's not unresectable. It's 30% of our series. So this is the match in between. But I am confident that I can step down immediately.
Hey, yeah.
Guido,
Oscar.
Congratulations once again. Really, I'm also a great fan of you. 2 questions. The first one is, do you have different strategies between patients with RAS mutations or patients wild type? And the second one is, how do you plan the operation? Do you perform in the console of the CT scan? How do you
CT scan,
plan?
PET scan?
This is a multidisciplinary board with the imaginologist. How do you plan the strategy?
So the preoperative staging is always CT, chest, abdomen, superior in particular for the cast. Because the system we have does not allow to do the cast with MRI, that anyway we have to do. Because I want to do the Primovis phase and I want to see despite most of the patients, unfortunately, come from other hospitals, and the other hospitals, especially the oncologist, sorry for the, but they don't recommend MRI. They use the CT, and we need the comparison between the same technique to see if there are really the same lesion and we can recognize any disappeared, because if you do this surgery, it is important to monitor any disappeared lesion, because it may change. If you amputate, the organ is less important. And then every patient undergo the multidisciplinary team. Any patient that is addressed to the Department of Surgery, 100%. It's not the reverse for those who receive radiotherapy, oncology. They at first treat and they submit to the.
So that part about RAS wild type, RAS mutated.
We have published a paper. The results are not convincing to me. We published because it seems that R1 KRAS mutated protect against recurrence in the R1 vascular. But I may say that I want to investigate a larger number because I really I'm not convinced of this data.
Mr. Clavian? Yeah.
Just a short comment. Number one, I think everybody can only congratulate for this extremely fancy, complicated surgery. Congratulate you because you're really persistent. I think coming with this, already you know a few people who seem to do the same. My call is again the same. If you compare from the ALPS registry stuff that 10 years old now, with all the confounding factors, I think we never have the answer. I don't want to be paid. We will never have the answer. You have shown are feasible. I think that you've demonstrated. We have to agree with that there are some good results, some less good results, could be a bridge to trauma, but really a conclusive answer for patients with many tumors between two-stage hepatectomy and this one, I think we never have the answer. We can program debate for the next 20 years with no data. You cannot. And a randomized control trial would be almost impossible on the same way because that's different expertise. You have belief, you have expertise. Not everybody can do this surgery. I can guarantee you that most of the surgeons, and speak about HPB surgeons, they don't have the character, the patience, the knowledge, whatever, to do this. The ALPS is much simpler operation when we compare to that. I mean, it's relatively simple in some way. In terms of the, so we have no randomized trial, and if it's seen by other people of oncologists or whatever, they may laugh at us because we are just talking about technology, what we can do, but totally inconclusive. And without being, I think we can show feasibility, some long-term result, but compare one with the other one, I cannot imagine we will be conclusive. Maybe you can comment on that. It's not a question.
Yes, I am pleased to comment because there are tons of comparison between the stage and ALPS published elsewhere, also on the top journal, even though they were methodologically exactly the same that the one that I published on digestive surgery. And also there is a paper published on anastosurgery, radiofrequency plus and this paper was done to you by the Gustave Roussy because they were hearing that we were dealing the other paper that unfortunately wasn't. So the methodology is important, I agree with you, but none of this study, also those who are more visibility, have been proven anything. The problem is that if I read a paper on Nature Gastroenterology, I made a mistake before, in which the portfolio of the procedure, there is not this one, I just say, please, there is no proof, but there is. And then it should be discussed. I know, I take time, and then this is because I am enduring, because I am convinced, and I think that in the community should be considered a solution. It does not depend on because this kind of operation has started and proceeded with a level of safety that none of the two has the same. We can then, if it was not aborted, the other two, with such a level of complication that they were associated with for advanced disease, we are discussing about the resection that has the possibility to give these results for 0.7%, more than 500 patients. And it is, once it is repeated elsewhere, it is the same. So it is safe. There is also something new to investigate that should not be investigated by me. In example, I told you, and if you are curious, you can show, if you leave the pedicle and the in and the outflow, and there is a few liver, it regrow a nice new liver. But if you amputate, it will not regrow. And this is an advantage, in example, that it is difficult to measure. So I am not pretending to prove that we are better. I am asking, pretending I cannot, that this should be an option classified. And I think that now there is room for that. That's all. ALPS and two-stage has had the same course. There was no randomized trial, and also ALPS.
There was one, but that's not. No, I'm not saying, I'm not trying to do a debate. What the message is like the FDA testing new device. We should forget to show superiority. What we need to show is that they are safe, they don't kill patients, and then there is so dependent of the expertise, etc., that we will not go further than that. So I think this is safety, feasibility, some long-term data, but you cannot compare to the other ones. It's like, it's not testing drugs when you need to show superiority.
I know, Pierre.
It's testing a technology like the FDA does, and we need to test safety. And I think you have shown that.
I agree, but if I would have not done what all of you have done for the other techniques since 10 years, there could not be even the discussion, and someone would say, why you didn't compare? We compare, so we have the comparison. I know that is not definitive. There are a lot of bias, but we need also this aspect to get seated at the table in which, please, include R1 vascular surgery. That's all. Safety.
Okay, you are terribly convincing. Thank you. Okay, we are moving on. On the same theme, it will be difficult for you, René, to justify liver transplantation for colorectal metastasis after Guido. Is it? Okay.
Button there, René.
Thank you. The chairman is very useful, you know. So no, my talk would not be a general talk about liver transplantation for non-colorectal metastasis. It would be a talk, I would say, paying attention to some point that we as surgeons have considered a very easy way to go for the best treatment, meaning feasibility, technical aspect, and outcome. So in terms of technical aspect, feasibility mean what type of allocation. And indeed, we are faced with such type of multinodular non-resectable bilobar liver metastasis, several lines of chemo, potential aggressiveness, mandatory tumor control. And because of organ shortage, of course, we will have, for cadaveric, a long waiting time in the waiting list. And so we need priority access to transplant. And for that, we have presently two models. The Norway model, which is very simple. You ask for a liver, and in 17 days, you have it. And all the other models of cadaveric liver transplantation, which are much less simple, mean waiting time usually 6 to 12 months, MELD score unfit for those patients, and we propose that the time to liver transplantation should be less than 2 months. You will see what are the results to avoid tumor progression. And for that, I give you the first result of the randomized trial, Transmet, who compare chemotherapy with chemotherapy and transplantation. And the originality of such type of trial was that we have an independent validation committee to avoid such type of, I would say, compassionate indication, because we know that as surgeons, okay? And from 157 patients submitted by tumor board, specialized tumor board in France, Belgium, and Italy, we come to only 63 non-eligible, patients, meaning that 40% of the patients were excluded, while referred by expert tumor transplant with tumor board meeting. And this was because of the unresectability was questioned, 21% of the case, because of tumor progression, hepatic, extrahepatic, or hepatic and extrahepatic, because of more than 3 lines of chemo or chemo resistance, it was in the eligibility criteria, or for other cause. So the first point is that it's not so simple. The second point is that when eligible patients come, 60%, and were randomized, 47, we come to the fact that from these 37 patients randomized in the group of liver transplantation, only 38 were transplanted. And so 19% of the patients were not transplanted because hepatic progression before LT, extrahepatic progression, intraoperative finding of extrahepatic location, detection of a prostate cancer on a pre-transplant checking. And so for that, the median time for liver transplantation was 50 days, which was not so bad, knowing that the objective was to transplant the majority of patients within 2 months from the last chemotherapy cycle. And from that come what type of donor. And when we see now the literature, the majority of donors are living donors. Here you have the US experience, where 56.5% of the donor used for liver transplantation in such type of indication were living donor, okay? And if we see, I would say, the experience of the Toronto group, and this is the combined experience of the US. See, from 91 evaluated patients, only 11% come to liver transplantation, even with a living donor. And if we compare this with the Toronto experience, also using living donor, the same proportion. Only 9% of the patients that were referred were finally transplanted. So living donor does not seem to be, I would say, something which solve all the problem. And of course, we imagine some technical refinement of the technique, and this was proposed by the Oslo group, which is very interesting, the rapid concept, which clearly consists of, in such type of patient, as you know, to make a left hepatectomy, letting in place the right liver with a lot of tumor, then transplanting a small left lobe coming from a living donor or a split liver cadaveric transplantation, cadaveric donor, and then after 15 days to transplant, I would say, to remove, after hypertrophy of the left liver, to remove the right liver. This has been done in this, I would say, combined analysis, 23 cases, with a low donor morbidity, 4%. Early postoperative mortality was not so nil. It was 4.3%. And the conclusion was that such type of technique make that, in fact, we can consider this as safe. Now, coming to the risk of the procedure. As liver surgeon, experienced liver surgeon, we said initially, in theory, such type of indication is less risky. No cirrhosis, normal liver function, no portal hypertension. But in reality, it's challenging because we have CASH, liver damage by chemo, previous hepatectomy, history of prolonged chemotherapy. And in fact, when we come, I would say, to our randomized study, the first result shows that 3 patients were retransplanted, of whom 1 died of multiple organ failure. And when we compare this to the literature, what we see is that from to date, all the reports show that the mortality is not nil, that the clavien d'Indo more than 3B complication is around 40%, and that a risk of retransplantation, of course, exists. Now, coming to the outcome, the same, I would say, line of idea. We are all convinced that transplantation is the best treatment, should give fantastic result, and so on. This was the old result of the European Liver Transplant Registry, who make it as a contraindication. Okay, this has changed, and the group of Oslo has published 60%, as you know, 5 years survival.
confirmed by a companion study made with Christian Tozo and 4 of the center of the Compagnons, showing that disease-free survival and overall survival at long term is possible, okay? But we are speaking about overall survival. If we come back to the 60% overall survival of the Oslo group in the initial report, we should have in mind that 19 out of the 21 patients transplanted recurred. And so they evidence something which is, in my view, very important, that the tumor recurrence after liver transplantation concern 2 different entities. One is pulmonary recurrence, which is an indolent pattern with a 72% 5-year survival, and hepatic recurrence, which is much more severe with no survival at all at 2 years after recurrence. And if we come now to more, I would say, refined selection of the patient, which is the SECA2 experience of the Oslo group, they were transplanting patients in tumor progression, which is for us a contraindication, and indeed now they are exigent with at least 10% response on RECIST criteria, with a time from diagnosis to LT more than 1 year. Even for that, they come to excellent results, 84% overall survival, but see what is the disease-free survival. Less than 40%, meaning that it should be kept in mind the fact that recurrence is a frequent event after liver transplantation. So, to conclude very quickly, on feasibility, as a non-resectable colorectal liver metastasis represent an aggressive disease, feasibility represents the first technical limit for such type of indication, owing to the scarcity of organ, and to avoid such too long waiting time and tumoral progression, we have either choice of access priority to whole cadaveric liver, or with the alternative of living donor or rapid technique. For eligibility now, beyond the selection of specialized tumor board, 40% of patients might be excluded by an independent validation committee, meaning that a lot of compassionate indication may be done. Once selected now, almost 1 of 5 patients could not succeed to be transplanted because of tumor progression on the waiting list, despite, in our study, despite a prioritization of organ access for such type of indication. And the feasibility does not seem to be highly facilitated by living donor, as it's shown by the Canadian and the US experience. For risk and outcome, risk is not nil. It includes a Clavien-Dindot more than 3 complication rate around 40%, 3 months mortality between 2 to 4%. 5-year survival is very good in hyper-selected unresectable patient, but recurrence remain a challenge, indolent for pulmonary, but with a poor outcome for liver and the other side, leading now to consider probably 10-year rather than 5-year survival, and disease-free survival also compared to overall survival for the long term, and still refinement in the selection process are needed. So the promising results of retrospective study still need to be validated on an intention to treat, considering the impact of organ shortage, to definitely validate the indication of transplantation for unresectable patients. Thank you.
We call Carlos Posito as discussant, please.
Professor Adam, dear Chairman, thanks for the excellent and interesting presentation. I'm here to discuss these results because also here in Italy we are running a trial on colorectal liver metastasis with Professor Mazzaferro, and we actually enrolled 22 patients. We transplanted 22 patients over 34, and we have 7 on waiting list. And I wanted to underline that also in our cases, as in yours, we experienced the same. That is, that was not reported by the Oslo series, and that is feasibility of liver transplant is lower than expected in terms of eligibility. and that there is a dropout unexpectedly high. We also had 5 dropouts on waiting list or at laparotomy, which is a dramatic occurrence and something that was unexpected. And also, sometimes we found 2 patients with nodal positivity at laparotomy, which is another thing that is unexpected. My question is, probably we did not understand everything about selection criteria. And this occurred also with neuroendocrine liver metastasis. It is more difficult than for primary liver tumors to understand the predictive factors for recurrence and for dropout. And I wanted to ask you a comment on the possibility that probably the super selection of the Oslo criteria was also given by a very long time from diagnosis to transplant that actually, at least in Italy, we did not respect. We had 9 months from diagnosis to transplant, and this is probably one of the factors impacting on postoperative outcomes and on dropouts. But this is a reflection that I wanted to share with you. Thank you.
Thank you. Interesting comment. Indeed, the interval between, I would say, the colon resection and the transplantation is a very important criteria in the Oslo group. However, in our experience, the majority of patients have synchronous metastasis, and the vast majority of patients have received the liver first, I would say, approach. I mean, we have considered the liver initially because some of these patients have been resected before transplantation, and in such a way that to consider such type of interval for us is no more, I would say, selection criteria. Other criteria may be important, for example, right liver, I would say the mutation of RAS. We exclude the patient with RAF mutation, but not patient with RAS mutation. It could be that in the near future we will go again, still with a more refined indication, but in my view, the delay is probably not adapted, at least to the patient we have transplanted in the randomized study.
I have a question. In fact, you finish talking about the refinement of the selection criteria. In fact, I guess we are doing the same mistake than before. We are transplanting patient unresectable and very ill patients. So do you think that transplantation would be much better for patients, you know, those patients with a lot of metastasis? I'm sorry, Guido, but a lot of papers said that when there are more than 10 metastases, the recurrence rate in the liver is more than 80%. So they recur in the liver. So should we just perhaps study those patients who recur once, twice in the liver, but resectable, and they finish to be out of the liver and it's finished? So do you think that the future is not to select chemotherapy, but select patients less ill than now?
Very, very good question. And I totally agree on, I would say, the rationale for that. And my view is that if you see all the transplant oncology, and I have made this statement yesterday, what we see is that the less, I would say, is the tumor load, the best are the result, and the best is the chance of cure. Milan criteria, cholangiocarcinoma, Klatskin tumor have shown what? That we should transplant patients with a tumor load which is lower. Now, for colorectal liver metastasis, it's a different problem. It's a two-stage way. The first stage is to convince the medical community, gastroenterologists, hepatologists, but mainly oncologists, that there is a rationale to propose liver transplantation for patients usually treated by chemotherapy, and to show that unquestionably the results are much better with liver transplantation combined with chemotherapy. But in a second stage, I think it will be interesting to compare what you propose, to compare marginally resectable patients in which Guido is doing such type of technique. We are using ALT. We are using complex two-stage hepatectomy with, finally, we should recognize a high risk of recurrence. Probably this patient, marginally resectable, could be a still much better indication to liver transplantation. But today, in my view, it's too soon. But
okay, thank you. Oscar, you want to comment after?
Thank you, René. You're always updating us about this subject. A few questions. The first one, do you have some chemotherapy, post-transplant chemotherapy protocol for all this TransMed study? This is the first one. The second one is, did you find some different pattern of recurrence in patients who had, for example, rejection and needed boosters of steroids, or the different complications? Or I don't know if you have studied this issue.
Mm-hmm. So indeed, we recommend to all the team to do post-operative chemotherapy. And around 68% of the patients receive chemotherapy. It's not, by definition, a fixed protocol, because the medical oncologists of each center are doing the same chemotherapies that were working before transplantation, and they were doing the same in the post-transplant. And it could be very different from one patient to the other. Now, to have result about that, we have no result at all, because we still, the database is not freezed to make the total analysis of the data. And so, with regard to the complication, we have presently no data about the difference between those patients resected with before transplantation, not resected before transplantation. This was your question, or it was about immunosuppression?
About rejection after transplant. Rejection.
No, no, frankly, we have not been faced with the severe acute rejection in such type of patient, and we use tacrolimus, steroid, and mycophenolate mofetil, and within 2 months we try to change mycophenolate mofetil to everolimus.
Okay, we have the two Eduardos.
Yeah.
The first one,
the oldest one first. I don't know if my English is enough good to put the provocation I have there. First thing, we don't need nobody to send us that kind of patients. We don't need to convince nobody. That patients belong to us, liver surgeons who have already treated that kind of patient. So I don't need that any oncologist send me, Eduardo, our center, do you think that patient with metastasis to transplantation? No, no. We don't. The patient is already with us. Because, and the second thing, I don't need your study to decide what kind of patients I need to transplant for liver metastasis. If I tell you the history of our first that could be arrested in Argentina, I tell you, the patient was a patient of us. We have treated 8 years before the first liver resection for liver metastasis. A second recidive 3 years after, something like that, only on the liver. And the third one on the liver only after 8 years. Only on the liver, a patient with 44 or 45-year-old. I don't need any study, randomized study to put that decision was obvious for us after discussing 15,000 patients in our center, 15,000 patients in our center. How can I refuse an obvious indication? Of course, that lady could be transplanted, and what will be was unbelievable not to give her the chance to have a fourth resection. And the fourth resection was not a partial resection, was a total resection. And we did a total resection with conviction. And the patient is alive 20 years after. So I don't need your study to decide what some kind of patients that we need. And that patients, and you don't need to convince the community, the gastroenterologist, the oncologist. you need to convince them to send us the metastasis to partial sections. It's a very good thing. After that, we begin to take care of that kind of patients. Obviously, you have, after to do 2,050 liver sections are not supposed to do an individual choice for some kind of patients. So thank you very much for attention.
Eduardo, so I agree and disagree with you. I agree, and I think if we make a quick survey, 100% of all the members in the audience are convinced. This is the point. I agree with you that I don't need to be convinced. I'm convinced. The only problem is that we are academic surgeons. And one of our tasks is not to cure only our patient, is also to convince, I would say, the other surgeon, the other specialty, about the rationale of doing what we are doing. So this is my view. And for that, I remember you, for example, and you have the memory of Portagaval shunt. You remember the history of Portagaval shunt. Everybody was totally convinced on the fact that a cirrhotic patient with bleeding who has a Portagaval shunt with no more bleeding, it was evident that we improved the survival of this patient. 4 randomized studies come between the 70s and the 80s who show no benefit in survival. And it was the death of Portagaval shunt. I'm not saying that because I'm convinced that it will not be the case of liver transplantation, but sometimes we are convinced of something that needs to be evidence-based confirmed.
I agree
Okay.
But can I just make a very quick point to add to what René said? We need to convince one other group, and that is the medical authorities. Only with data like this can we convince, for example, in the UK, to allow colorectal mets to be an indication for transplantation.
Don't react so strong against. Was a provocation? I agree with you also.
No, it's not a provocation, but we need that data. So, other Eduardo.
Yes.
Of course, fortunately, we are among surgeons. Okay, Eduardo.
Is regarding chemotherapy, and why not to? You said that maybe you need a post-transplant chemotherapy. Now that we can have a Signatera and we can dosage DNA in blood, why not to be more rational? Because maybe when you perform the liver transplant, the patient is the best R0. And maybe if the Signatera is low, and now is more cheap than before to dosage the DNA. Why not to be more rational to apply the chemotherapy? That's my question.
No, it's a good question. And now we have tools that we haven't at the initial part of this randomized study, because we begin in 7 years ago. At that time, the ctDNA, the circulating tumor cell, was not so a useful tool as it is recognized today. But I think it's an interesting way. No ctDNA negative and so on, no chemotherapy. ctDNA positive, at that time, a good indication of chemotherapy in an adjuvant setting.
Interesting. Hugo.
So, first of all, I also share this view that biomarkers like Signatera are going to be very important to select those patients. 2 quick things. First of all, at the point where you accept that you are starting to do liver transplantation for colorectal metastasis, we end up seeing that we have much less candidates than those that we first anticipated. So I think the number of candidates is actually much lower than we thought. I don't know if you have the same impression or not, but with such a large pool of patients, how come we have such few candidates? And the first and the second thing is the place of living donor. What do you think?
I respond to you to the first question, which is very close to that of Eduardo Barroso. We have to convince the medical oncologists that this indication exists, because I have very good friends, medical oncologists, who said to me, I don't believe in liver transplantation. How to convince them? And they are very authority in the field of digestive oncology. They said to me, René, I don't believe in liver transplantation. No, see the result. I don't believe. So only factually we can convince them, and having more patients recruited. And you will see that in the near future, if we can convince them, the thing will change. And the second question was?
How do you see living donor liver transplantation in this setting?
I think living donor will come in a second stage, I would say, because today in France, at least in France, it's impossible to use living donor for a non-validated indication. Once the indication will be validated, no problem for doing living donor. And it's a good indication for me.
Gordon?
Things have been said. I think a group that will be extremely difficult to convince without this kind of data is the hepatologist community.
It's?
The hepatologist community, because it's not really only the medical oncologists who hold the key to this, but the hepatologists have very strong feelings about the allocation of livers to patients that they don't really always consider to have, entre guillemets, liver disease.
Sure.
So it's a very, we've encountered this dynamic and this almost wall of why this is, again, very important to have this kind of information to convince the community. I think the transplant hepatologists need considerable education.
It's a very important issue, Lee. A very important issue when I present this to Agence de Biomédecine, which is our Society of Organ Sharing. In fact, many hepatologists said, oh, if you put colorectal metastatic disease in the indication, you will take all the livers, we disagree, and so on. Today, factually, this represents no more than 1.5% of transplantation done in the European country concerned by this indication.
This is why it's so important to disseminate this information to these communities, I think.
Sure. Mm-hmm.
Yes, this is a major point of this study, and I have to congratulate René, because I remember they said, you opened the Pandora box. There are too many patients, and it is in the fact that you form that committee to examine each patient. It was really rigorous, and I think that's the way to convince that we are responsible for this indication. Christophe, another comment question.
René, thank you very much. Great talk and inspiring, like usual. Regarding our discussion about the medical oncologist and the hepatologist, transplant hepatologist, did you elaborate or have any idea how to survey the patients after liver transplantation, no matter whether they receive chemotherapy or no? Are there any special biomarkers, CEA, ctDNA, whatever? Do you have any idea or any about it?
Thank you for your question. We have not used this tool up to now, but all the patients are followed not only by the transplant surgeon, but the medical oncologist in charge of the patient initially, and also the hepatologist or the gastroenterologist in charge of the patient initially. So this is a multidisciplinary follow-up of the patient also.
Given that about 80% of those patients have a recurrence, I think that we have to be very, very precise to build a kind of surveillance, the protocol.
But this was very well protocoled. Every 3 months, the patient has a CT scan, MRI every 6 months, PET-CT every 6 months, tumor markers every month. So this was very well protocoled in the trial.
Thank you.
Professor Bismuth?
It's time to close, I think, the discussion. I have only one question. If we consider the total population of patients with colorectal liver metastases, how many do you think are alive after 5 years? The total population? Less than 20%? 15%?
It could be for the global population, it should be less than 5%, because we know the resected one is 25% at 10 years alive. If we mix this with all the non-resected patients, it will lower probably around 5%, no more.
Do you think colorectal liver metastasis is a surgical disease?
I will not respond to this question.
Thank you. Now we are really depressed. Okay, thank you, Ronesh. Professor Aldegrete, it's my pleasure to introduce you to speak about the place of minimal access surgery in surgery of colorectal liver metastasis.
Thank you. Thank you very much for Guido for your invitation. It's a great honor to be in front of this community. So I have to answer which is the role of minimal invasive surgery in colorectal liver metastasis. So the first answer is that laparoscopic is superior to open liver surgery for colorectal mets. This is a paper we published, I think, 5 years ago, almost 900 resection, splitted by approach and then divided by propensity score 1 to 4, and we find advantages of laparoscopic approach in terms of blood loss, morbidity, transfusions, and postoperative stay. And if we go higher in the pyramid of evidence, we find a prospective randomized trial from Oslo that is basically saying the same. There are advantages in terms of lower postoperative complications and a lower hospital stay. And what is important is that in this study, we also can see a lower inflammatory profile in those patients operated by laparoscopy. And finally, at the top of the evidence pyramid, we find also a meta-analysis that was published last year that is giving the same results. So there is a benefit in terms of postoperative course, complications, and in this meta-analysis, there is also, in a way, suggested a better oncological outcome. So that's why I think that minimal invasive activity is mandatory at the present time in any center which is working on colorectal mets and in general in liver surgery. And indeed, this is a survey published 2 years ago that is telling us that in high volume centers, almost 30% of resections are done by laparoscopy. So the true question is not if laparoscopy is superior to open surgery in colorectal mets, but the true question is if minimal invasive surgery is feasible for all patients with colorectal mets. And if you look at this point of view, well, we see definitely a different picture. These are the data from the IGO-MILS registry that is presently data from almost 8,000 patients. And you can see here that only 40% of the patients with colorectal mets are actually operated by minimal invasive surgery. And if we look at our experience, we are just above 2,000 minimal invasive resections, including laparoscopic and robotic resections. But if you look at this part that is recording the activity of 2022, as you can see, there is a wide space for open surgery. 3 types of techniques: open, robotic, and laparoscopics, and basically each of them is getting 1/3 of the activity. And going into that, again, the activity of the last year, 341 resections. And if we look by diagnosis, you can see that while more than 85% of resections are done for cholangiocarcinoma and for hepatocellular carcinoma, only 50% of resections are done by minimal invasive approach for colorectal mets. These are the features of the series. And indeed, in spite of the fact that in our center, all patients are candidate at first to minimal invasive approach, we have some contraindications to MILS. And as you can see here,
Some of them are specifically applicable to colorectal mets. So multiple and complex resections, parenchyma-sparing resections. Obviously, we are talking about colorectal mets, so we are on principle talking about parenchyma-sparing resections, lesion infiltrating major vessels or vena cava, and so on. These are some of the pictures of the last year that is telling you that even if minimal invasive surgery is superior, we actually have difficulties to apply this technique to many patients with the colorectal liver metastasis. Here are some pictures of those cases operated last year, and here some need of complex cooperation with grafting or prosthesis. The major factor that is influencing the possibility of minimal invasive approach for colorectal mets is for sure the number of the lesions. This is a paper a couple of years ago actually, that was focused on synchronous resections, 3 series, and when we go above 4 lesions, it's maybe already a problem to enroll the patient to the minimally invasive approach. And indeed, in this paper, that was asking to many surgeons their point of view in terms of approach to clinical cases, what we see is that the more complex is the case, the more all surgeons agree with open approach. So we need, in a way, to find a balance between the feasibility on one side and the advantage on the other side that we have recognized in many papers comparing open and laparoscopic. In spite of the fact that apparently the high is the difficulty, the larger is the advantage if the patient is operated by laparoscopy. This is a paper we published last year showing basically this concept that in low complexity cases there is not a large advantage, but in the intermediate, in the high difficulty patients, we get more advantage if we are able to operate the patient by laparoscopy. On the other side, the real problem is that we are often not able to operate this patient by laparoscopy, or at least we need a prolonged time when compared to open surgery. And these papers are telling us that operative time is not something that we cannot forget. When we go to a very long operation, we may give to the patient a bad impact just because of the duration of surgery. And the length of surgery is actually a consequence of number of lesion, size of lesion, location of lesion, relationship with vessels, the number of transection surface. This is another important point. Obviously, it's not just the number of the lesion, but it's also the type of resection that is needed. So probably we need, and I don't have an answer about that, we need to define some specific models that are able to define where is the limit of the benefit of minimally invasive surgery when applied to colorectal mets. Basically putting together number of lesion, size of lesion, the depth of lesion, the extent of resection areas on one side, and on the other side, the advantages that we have already recognized of minimal invasive surgery, including a low inflammatory profile, lower blood loss, and lower morbidity. As I said, I don't have an answer. This is the way that we have to work on. Probably we need models by applying deep learning, machine learning, or artificial intelligence, because it's so complex to put together all this data that it's very hard to draw an answer without a specific model. I don't have still the final answer, but it's going to come. We are working with some engineers to define a model based on the artificial intelligence, specifically to define when we shouldn't go for a minimal invasive approach in colorectal liver metastasis. We are working on the data of the EGOMIS registry. We know at this point that topography, number of lesion, and size of lesion are definitely important, but as I said, the answer is not here yet, but it's going to come soon. So my conclusion are that even for colorectal liver metastasis, minimal invasive approach is gaining the momentum with clinical outcomes that are favorable and results that have been documented by large cohort studies, randomized controlled trial, and even a meta-analysis. Oncological results are adequate, if not superior, if we look at that meta-analysis. But two are the most important point. First, any liver transplant, any liver resection program need to work with minimal invasive resection also in colorectal liver metastasis. This is one point. But the other point is that minimal invasive liver surgery is not the dominant approach for colorectal liver metastasis when compared to ACC or cholangiocarcinoma. Probably the number of the lesion is the easiest factor affecting the indication to MILS, but we need more sophisticated studies to put together on one side the advantages of the MILS and on the other side many factors that can affect negatively the outcome. Thank you.
Yeah, so Guillermo for the discussion, please. Yeah.
Thank you for your nice presentations. So you know that the minimal invasive surgical approach to liver sections has been increasingly adopted to treat the colorectal liver metastasis. So you know that the laparoscopic liver approach to treat the colorectal liver metastasis is associated with less intraoperative blood loss and short hospital stay when you compare with open approach. So the operative time is the same in our days. When you compare the robotic liver approach, you know that in some cases, in some series, the rate of improved R0 margins, so it's good, but you know that the surgical minimum approach can reduce the time from the surgery to the initiations of the chemotherapy. But there are papers say in other hands, you know that some series are some papers show that there is no significant difference 5 years overall on disease-free survival between the 3 laparoscopic, robotic, or open approach. So I think the more important is the surgeon experience. The more important is not only the surgeon experience, is the surgeon experience in that sense. So the experience of the department, or the surgical department. So this is factor, in my opinion, should be part of that decisions. Thank you. So a comment for you.
We'll go to questions. Hugo.
Luca, thank you very much for this very nice presentation. I want, first of all, to congratulate you for your robotic program that I see that is growing very fast. You have almost 300 resections already. And I wanted to ask you a comment on this, because for us, for example, one of the main groups where we select less patients for minimal invasive approach is precisely colorectal mets. And it's not only because of the number. Of course, it's much more cumbersome to treat 10 or 12 or 15 metastases by minimally invasive approach, but also because sometimes it is very difficult to find small metastases because you don't have the tactic sensation, and also because the performance of intraoperative ultrasound is less optimal. What do you think of this?
Yes, probably. When I say that minimal invasive is not feasible in half of the patient with colorectal mass, I put together a lot of things, including what you said. I don't have an idea if laparoscopy or robotic approach can really change the situation. For example, by ultrasound, I think the possibility to work with the probe with the robot is better than laparoscopy. Maybe with the robot it's possible to do more complex resections, but I don't have a feeling about that. For sure, what I think and I want to stress is that there is no conflict between a minimal invasive approach and open approach for colorectal mets. It's just that we need to understand when the benefit of minimal invasive approach that is clear in a group of patients is lost by other factors. And so when we shouldn't push with the minimal invasive approach, losing advantages for the patient. And so this is where we need to work on.
Another expression is, I think that to remove more than 10 metastases is definitely not a minimal invasive surgery, whatever the approach.
Well, you know, it depends on the postoperative outcome. If you have a better postoperative outcomes in terms of morbidity, blood losses, hospital stay, functional recovery, that's a minimal.
Yes,
I don't know if you understand my point.
Yes, of course. Minimal invasive is a good outcome.
Okay.
It's not the approach, it's the good outcome.
Exactly.
You can say it's minimal after surgery and not during surgery. That's what I mean. And honestly, when you have more than 10 metastases, you need something, well, you'll have some morbidity. So whatever the approach, it will be minimal, this type of surgery, 10 metastases.
Yeah, I totally agree with you. That's why, as you saw, this is a specific contraindication in our center. We don't even try. And that's why I think we should put together data and efforts to understand and in a way to standardize when the advantage is lost.
Exactly.
This is what we don't know. This is what we don't know.
We'll go to Gina. Can I just quickly ask you a question first? Are you finding with the development of the techniques and experience and based on the outcomes in terms of shorter length of stay and less blood loss, at your multidisciplinary tumor meetings, are you thinking of minimally invasive as the default approach and then find a reason not to do minimally invasive?
It's certain that we define at the tumor board the type of approach. And we don't like to put that issue in the discussion. So we do not operate a patient because the patient can be operated by minimal invasive approach. The decision about the approach is then, in a way, a specific surgical decision based on what we feel can be the feasibility, we are talking about colorectal mets, and the outcome.
Gina?
Yeah. How do you integrate the management of colorectal liver mets? Meaning, when you make your decision in your tumor boarding, I understand that you will choose, of course, minimal invasive approach for that type of patient. Do you integrate also the concept of transplantation for colorectal liver met? Meaning, do you have a large view, or do you decide, I need to do only this approach? Or is it really I'm treating the disease.
In our center, we don't have a liver transplant program, and that's why we have a specific convention with the liver transplant center. So the issue of a possible liver transplantation for colorectal mets is already discussed, and obviously the patient is then referred, if considered a potential candidate, then to all the evaluation in our referral center.
And the last question, if you don't mind, and what is the rate for repeat hepatectomy in case of recurrence? How do you approach them?
Oh, we don't think a previous surgery is a contraindication to minimal invasive approach. You saw the contraindication. So out of there, the patient is considered for minimal invasive approach.
Thank you, Luca, very much. My question is regarding imaging with a minimal approach. Is the quality, because we have developed a robot to operate that is very expensive, but we have not progressed many in the fusion of imaging, in the intraoperative fusion of imaging. That I think it can be supported by the new technology. What do you think about that? And the use of the common intraoperative ultrasound has the same sensibility that the use of in the open surgery?
I would be happy to have something for intraoperative navigation. I have to tell you that one of the problems with minimal invasive surgery is that there are areas of the liver where if you are not really experienced, you may lose your right direction. Maybe in posterior segments, maybe deep in the posterior part of the segment 8. Sometimes you need your own experience to understand how to draw the transaction plan. And this is not good for the community. Obviously, we should have instruments that can avoid a surgeon to become experienced before understanding how to do things. So I totally agree with you. We need those tools.
Thank you, Professor. I have a question about combined approaches with intraoperative thermoablation. Does this kind of strategy influences your choice in minimal invasive or open access?
As I said before, at the tumor board, we decide how to manage the patient, including if in multiple colorectal mets, some patients are good candidates to combine resections and ablation. And then we decide about the approach. So again, we don't take the patient to the minimal invasive approach to avoid some resection and do some ablation, even if the patient is not a perfect candidate to ablation. I don't know if I'm clear.
No questions. Thank you, Professor Andrietti and Guilherme. Thank you very much. I understand Dr. Vorti has arrived, but it's a little bit late with the timing tomorrow. We're going to have his talk tomorrow. Good, so we'll go on then to Matteo Donadon from Italy. Thank you. And afterwards, Christian Toso will be the discussant. And the topic is the bench research and surgery for colorectal liver mets.
Good afternoon. Thank you, Mrs. Chairman and Mr. Chairman, and thank you for the invitation, Professor Tozzilli. I'm honored to be here in front of such a great community of HPB surgeons. My topic will be about the bench surgery in colorectal liver mets. We know that colorectal cancer is one of the big killers. It ranks up to the third cause of cancer-related death. But we also know that since up to 70% of the patients develop colorectal liver mets, we know that there is an important effect of hepatectomy together with the system of chemo that allow us to say that we can reach approximately 50% of overall survival at 5 years. And this is a fact that is reported in the current guidelines. This slide shows the ESMO guidelines, the American guidelines, in which, as you probably know, in comparison with a few years ago, there is more and more space for hepatectomy, meaning that for sure hepatectomy for colorectal liver mets can be considered as one of the line of treatment. However, when, as a surgeon, sometimes we face some disillusion, in front of a patient that we decide to operate because of hepatectomy, because of colorectal liver mets. And for sure, I'm talking about the issue of mortality and the issue of recurrence. I will stay on recurrence, and the point is that we really need to focus on which are the main determinants of prognosis of our patient, because I agree when we talk with patients, because we are surgeons, on the sophisticated techniques to operate our patient. But the other face, of the medal is about if our surgery is associated or not with a good oncological outcome. This slide shows our series here from Humanitas, published last year, of about 900 patients discussed in almost 10 years in our weekly multidisciplinary team because of colorectal liver mets. Among these, 521 underwent surgery. If you look at the survival analysis and the multivariate analysis of the whole series, the factors that came out to be significant are almost the same we are used to read on papers, such as the lymph node status of the colorectal cancer, the KRAS status, the timing of metastasis, the size number, and of course, the level of CEA. So nothing really new. So the point to me is that probably we should make some efforts to try to don't think that prognostication is anymore an art, and we really need to have a personalized approach in reality. And so probably the way is to change the dogma, change the paradigm, and one of the way to me is to use really translational research. Everybody here knows what is translational research. I just want to point out that the famous slogan is from bed to bench and back, and not vice versa, which means that this type of research should run by clinicians, by us as surgeons, because we see the disease, we touch the disease, we know the patient, which is not the same for basic scientists. So which is the rationale? The rationale is the risk stratification, patient selection, improving communication with family and the patient, gathering data to guide the therapy decision-making, and hopefully limit some of the disillusion that sometimes we face in our patient. So the point is that we need to consider our operating room as a lab, because translational research is just a method to answer a clinical question. It's a way to integrate the best knowledge to address a clinical problem. And to me, there is a strong difference, between a human and mice. So mice is a good model, but we are not mice. So probably we need to spend much time to work on the real human disease. So the little story I would like to tell you is about my experience that I did here in Humanitas, because I had the opportunity to talk with some of probably worldwide famous immunologists that work here. And so the idea was to try to approach liver surgery through the immunosystem, to study the host biology more than the tumor biology, so to shift the paradigm of prognostic factors from tumor-centered to host immune-centered factors. And what we did was to start a systematic collection of samples of any patient we operated, so not only colorectal liver mets, but the main three diseases that we operate. So we collected tumor and peritumoral samples together with normal tissue. We apply a specific new original technique to isolate cells, meaning tumor cells, normal cells, and also any cells in the liver, together, of course, with the peripheral blood. And we focused our attention on the cancer-liver interface, so the space between the normal liver and the mets, the metastasis, or anyway the cancer, to try to define some new mechanism behind the tumor growth, the tumor resistance. I like to quote this paper from Anand, published last year in Cancer Discovery. It's an update of all the tumor features that characterize the tumor cells and the tumor growth in general. And it's interesting to note that each of these areas represent a specific research areas that in which we should spend time to try to understand, many problems we face in our patient. So I like to go a little bit in details, and I will give you some quick shots of our works just to make you aware of what we did so far. So this is one of the first papers we published after a meeting of the SSAT, and here we look at the intratumoral compartment, and we look at the rate, the frequency of NK cell and T cells inside of colorectal liver metastasis, and we were able to define two different groups of patients. First cohort of patients with a very high frequency of these cells, with a very, very good overall survival compared with the greater proportion of patients with low frequency of this tumor, meaning that intratumoral compartment is a good space in which we have to spend time, and in this case, NK and T cell may define the prognosis. Another really interesting research line we have open here, which has been awarded last year on a national grant, is about the relationship between RAS mutation and immune system. This was a preliminary paper published a few years ago in which we look at the difference in the frequency of tumor-associated neutrophils in RAS-mutated versus RAS-wild tumors, and we were able to find that the RAS-mutated patient had higher infiltration of neutrophil. It's interesting to tell you that this observation originally was because we realized during the operation that there was a difference, a physical difference of the colorectal metastasis, mutated versus non-mutated, meaning that the mutated appears to be macroscopical inflamed, and this was what we found. And the main research is ongoing, but for sure there is a strong relation with the RAS biology and also with the prognosis. Another research line is this one, which is still open. It's about tumor-associated macrophages, and we define with sophisticated analysis at least a couple of different subtypes of tumor-associated macrophages associated with a strong prognostic significance that could be used even on a routine basis to define much better the prognosis of our patient in comparison to other factors. And it's interesting to say that the same observation has been recently validated on an external cohort of a patient operated here in Milano in another institute. And so the thing is real. It's not just here in Rozzano. It's everywhere. And another research line, it's about unconventional T cells. In these two papers, we look at gamma delta cells, which are two relatively new cytotoxic cells. And in the first paper, we found, not really surprisingly being surgeon, that chemotherapy in some patients can give an impairment of T cells, in particular of these unconventional T cells, which means that tumor can grow paradoxically. And more recently, we defined a specific ligand for a subtype of gamma delta cells, which open a completely different scenario, because as you probably know, from ligand we go to look for checkpoints, and from checkpoints we can go to target therapy. So this is a very important line. And finally, the last paper I would like to quote is the most recent published on a sophisticated argument, which is the cellular senescence, the so-called zombie cells, which are specific cells that can be found in any solid tumor, not really new so far, we were able to define at least two groups of these zombie cells thanks to spatial transcriptomics associated with a prognostic significance. And again, this is an area that can be further investigated in the light of applied target therapy. So I'm going to my conclusion. Again, this is the slide I showed before. In the green, you can see the 7 areas in which we are working on out of the 14 proposed by Anand last year. And in conclusion, why benchmark research in colorectal liver metastasis surgery? Of course, because patient selection dictates outcome. We need to improve the knowledge on tumor and host biology, and we as a surgeon are in a unique position for this job by considering that OR is our lab. Of course, I'm not alone in doing this important work. Here there is a multidisciplinary team also for the lab, which include some surgeon, hepatologist, researcher, pathologist, and more importantly, the group members of people that really do the job. Thank you very much. Thanks for the invitation.
Now Christian Tosso for discussing.
So thank you and congratulations for the talk, but also for all the work by yourself and the group. I was impressed by all the data, but at the beginning you stated that in fact it's important to look at the metastasis, but also at the underlying liver and its immune status. But then, if I understand well, most of the results you have shown were looking at the invasion inside the tumor, inside the mets by immune cells. So my first question is there a difference between the immune cells inside the mets and in the neighboring liver tissue? So that's going to be my first question. My second question is, if I understand well, you have mainly looked at patients that were undergoing surgery and you were gathering samples at this specific time point. So did you see any impact between patients that had received chemotherapy before and those who didn't? And do you have any data, assessing how patients and the immune status behaves over time? And maybe my last question, and maybe most important, how do you translate all of that in clinical practice? Because of course now we have a snapshot on how it is at the time of surgery, but what I would wish to have is something prior to going for surgery, and maybe selecting patients that should not go surgery, maybe will do better with chemotherapy. Is there a way to gather all these data just based on a biopsy? Sorry for all these questions.
Thank you very much for the questions. For the first one, in most of the cases, these data came from the invasive margin, so the space between the normal liver and the tumor. I show a couple of papers in which look at the intratumoral compartment, which is, by the way, the most difficult compartment because usually not many immune cells can be found inside. But to me, we should look at the normal liver, meaning the distant part, even far away from the tumor, the invasive margin and the tumor, because to try to understand, all the story. The second question was about, was about...
with and without chemo.
Yeah, sorry. So of course, we got this data only from those patients that we operated. So we miss the denominator of the large proportion of patients. We don't know what happened in those patients that maybe Professor Adam or Professor Sposito transplant or you transplant, or patient who only does chemotherapy. We built our collection on this series, so we should open a start collection from patients treated only by medical oncologists.
But I'm guessing that some received chemo before surgery and some other didn't.
Yeah. Speaking about the colorectal liver mets, most of the patients got chemo. So even if we did in each paper multivariate analysis that mainly reported no influence of chemotherapy, meaning that the result is independent by the use of chemotherapy, it's true to say that most of the patients had chemotherapy. So this point should be further clarified.
And the practical?
The practical is something we are working on. Of course, it's difficult. We started a few years ago to work on some engineers to build an AI tool to help the pathologist, because in the real world there is a pathologist that read the slide. He or she, they don't have too much time to look for these small cells. So we built a research line to have a specific tool. The project is still open. We will see.
Thank you. Any question? Yes, please.
Nice talk. So I ask you, because in Coimbra, in our department, we studied desmoplastic metastasis and no desmoplastic metastasis. And we showed that in the decreased number of all monocyte cells in the patients with desmoplastic metastasis, so with increased survival of these patients. What do you think about that?
Yes, I know. It's an important observation. Thank you for the question. Of course, the type of tumor growth, the specific type of tumor growth has been reported in literature also by you, and it's when we talk about basic science, translational research, each area it's important to cover each area of this research. Personally, I don't have experience on that research, but it's an important point.
Thank you. Any question? Yes, I have a question, like a pragmatic question. No. Just you study intratumoral NK cells, and you see that it's a great difference in survival. RAS mutation also, spindle cells also, but all that you just study this factor. But there is a lot of other factors: clinical, chemotherapy, size, all that. So I just follow the question: could it be useful for with a biopsy, studying NK cell or spindle cell, anything? Because I don't. I'm not convinced about the real impact on survival of these solitary differences.
I have to say that in all of this research, we show that these data were confirmed by multivariate analysis, in which we put all the standard traditional clinical pathological factors that we as a clinician use to define the outcome, meaning that when NK cell came out to be significant, that was at multivariate analysis. Of course, the Kaplan-Meier was just a picture, but behind that there is a multivariate analysis. And this is the difference, because we as a clinician, we know that when we see a patient, we see a CAT scan with 5 colorectal liver mets, we don't see NK cell, of course. But behind the size, the number, the CA level, which we use, which probably nowadays are too grossy. You need something more in details to define really the prognosis of our patient. With the biopsy, yes, sometimes the problem is more technically from the research side rather than practical, because for some research, the amount of tissue you get with biopsy, it's
not enough.
Yeah, not enough.
Okay.
Okay, thanks. Thank you very much. We'll call on Christophe now, and Christophe's going to speak to us with an update on surgical management of breast cancer liver mets.
Thank you. Dear Compagnons, dear colleagues, first of all, I would like to thank very much Professor Bismuth, Professor Hugo Marquez Pinto, and Guido Torzilli for the possibility to present this paper. We have switched the topic, the most important topic of our first day, like colorectal liver metastasis, to another important issue, the liver metastasis from the breast cancer. As you know, so far, it's absolute contraindication to the liver transplantation. However, as far as I remember, the discutant of this paper, Professor Ettore, with his group, already published the first pilot study about this transplantation. What? Oh, it doesn't work. Sorry. Maybe I take this one. So, the breast cancer is at the moment the second most commonly diagnosed and second leading cause of death of cancer in women. To an example, about 300,000 new cases of the invasive breast cancer occurs, and the death toll is really very high, even in the best developed health system countries. 6 to 10% of the patient have the distant metastasis at the time of diagnosis, and only 27 of them reach 25 years survival. The predominance of the metastases are bones, lung, and liver. However, it's the poorest survival, the worst prognosis is for those with breast cancer liver metastasis. However, the recent international consensus guidelines for advanced breast cancer from 2018 present that resection is considered in selected patients. Quite recently published a paper in Journal of Translational Medicine showed that there are 5 important mechanisms involved in breast cancer liver metastasis. It is the intravasation from the primary breast cancer, then the circulation, margination in the liver, extravasation in the same organ, and colonization. Looking at the history, the first papers, the first informations regarding the surgery for breast cancer liver metastasis were published about 25 years ago. The first series were relatively small, with 50% patients without postoperative chemotherapy, with overall 5-year survival about 60%. The next paper, published 3 years later, the greater series of 52 patients with 3-year survival, differing from 48 to 82%. However, those patients have about 4 years time from the breast cancer diagnosis to the liver metastasis development. The authors emphasize the importance of patient selection for hepatic resection for breast cancer liver metastasis. Looking at the recent studies investigating the clinical impact of metastasectomy for the breast cancer liver metastasis, the first impression is that the median survival is from 42 to more recent studies, even 97 months. Of course, these data are biased by the very selected patients. Quite new, I know the authors quoted that the variables associated with outcomes mainly hepatic volume of the disease, the primary breast tumor hormone status, extent of liver resection, and long interval between primary diagnosis and liver metastasis. More recent study, prospective ones, proved the same rule about 57 months of survival up to 81 months in best group that all varied based on the receptor status. So in conclusion of this review, we know that independent predictors of the poor survival for the poor overall survival are number and size of liver metastasis, the subtype of the tumor, the best HER2 enriched and estrogen and progesterone minus FGFR2 plus, the longest survival about 81 months, and the so-called triple basal-like minus the very short, not the passing 1.5 months. 5-year survival in surgery group reached 56% versus systemic therapy group 40%. Also, quite recently published paper, research in BMC cancer showed that it was the analysis of 300,000 breast cancer patients from SEER and 1,700 patients from Chinese cancer registry. They showed and proved that the risk factors for developing metastasis are the young age of the patient, invasive ductal carcinoma, high pathological grade, triple negative subtype, already mentioned in the previous reviews, and human epidermal growth factor receptor positive. The longest median survival are for the human hormone receptor plus and HER2 plus subtype versus triple negative subtypes. Here you see the examples of the overall survival for the group, and here are the examples showing the particular subtypes of the breast cancer, the worst with the worst survival for triple negative. Very nice paper from Italian center published in World Journal of Oncology, analyzed almost 4,000 patients with non-colorectal, non-neuroendocrine, and non-sarcoma cancers. And as you see, almost 1,000 of this group were the patients with metastatic breast cancer. The authors concluded that surgical approach to those patients is essentially based on two fundamental issues. One is that liver surgery and liver resection become safer due to improved surgical technique, better pre- and intraoperative managing, and parenchyma sparing policy. The second issue is the complementary role of the new and very effective, very potent systemic therapy combined with the surgery. They found the most important prognostic factors that primary site and histological subtype, surgical margin status, adjuvant treatment, presence of extrahepatic disease, and number of metastases. In conclusion, those patients with the metastatic breast cancer and genitourinary primary site obtained the major benefits. The size of metastasis should be less than 5 centimeters, and the appearance of hepatic lesion longer than a year after the primary. At the end, a snapshot of the results we have obtained in our department in Warsaw between 2017 and 2021. We have operated on 25 patients for this indication, relatively young, of median age of 53 years, with different number of lesions from 1 to 12, very big discrepancy of the metastasis from 5 millimeters to 12 centimeters, obtaining different margins, and the survival median of more than a year, mean almost 2 years. The majority of the surgery for breast cancer metastasis were performed with the open approach, open surgery. For patients were operated on with the laparoscopic technique. The majority of the patients underwent anatomical resection. However, the 1/3 was with wedge resection. R0 was obtained in 87% of the patients. Here you see a few examples of the multiple metastasis and liver remnant after the surgery. The overall survival reached 50% after 5 years. In summary, the best candidates for resection of breast cancer liver metastasis are patients with limited tumor burden to the liver, with longer interval between a primary breast and liver metastasis diagnosis. The HER2 enriched breast cancer subtype responded to systemic therapy. Resection and ablation are warranted in carefully selected patients after discussion at the MDT meeting. Oligometastatic disease management should be driven by the predilection of the clinical team and patients' wishes. That's also important. And obviously, the randomized controlled trials are necessary to evaluate the most effective and evidence-based approach. Thank you very much for your attention.
Professor Ettore, yeah.
Compliment Christophe for this presentation, and you evocate my transplantation of the patient with breast metastasis. It was a patient, for the Compagnons, was a patient with only liver mets from breast cancer that was treated from 3 times for chemotherapy and radioembolization, and developed a real syndrome with ascites, and for this reason we transplant the patient for 1.5 years. But the oncologists say it's not possible to transplant, it's too dangerous, but we transplant and the patient is really well, 5.5 years. So I think that surgery and transplantation in selected case, you stratify very well the subgroup of the patient is a good indication. My question is, I don't say the time of stability of the disease before surgery. I think this is a really important point. We wait 6 months, and what's your opinion?
I think it is a very important issue. Of course, the longer the time between the primary, the better results. At our hospital, we have no breast cancer unit. That's the special places in the National Oncological Network. So the patients sent to us are already treated for a long time, at least a year or sometimes even more. So in case of stable breast cancer metastasis, in repeated imaging examinations, we qualify them to the surgery. So it's usually more than a year, sometimes 2, 3.
Just a question about non-colorectal breast cancer metastasis, but also other non-colorectal metastasis, because we have now, because of a new therapy, some indication quite disturbing, like oncologists saying that they control the disease outside the liver, sometime for breast cancer in the bones, but the metastasis in the liver does not respond. And they ask us to do something locally, although there is extra hepatic metastasis. Do you have this experience, and what do you do? Do you accept to do surgery in that condition?
Yes, in general, yes. Of course, we won't find the indication to the transplantation. But if those bone metastases are, let's say, dormant, and if they are ready to be to radiotherapy, of course we cooperate with the radiotherapist, and we try to find the best way and the best timing for both procedures: radiotherapy for the metastasis in bones and for the surgery, unless it's not, let's say, heroic surgery.
Okay, because in your factors there is no extra hepatic disease. The absence
in this series it ended 2 years ago. There are only the patients with only hepatic metastasis, but we tried to widen our indications and resign from very strict indications.
Okay, Pietro.
So thank you. We have a completely different approach, which is I really need the oncologist to tell me why it's helpful that we go and remove the metastasis. It could be dissociated response. It could be the only one. But it's rather than selecting a few positive factors, which are in fact the ones that are positive for breast cancer in general, so that I don't find very useful, is really a tailored indication driven by the oncologist telling, I need you to remove this because, and I have to be convinced for that. And I think that's the only way I can get out of the immensely evolving field that they have in their hands. And in fact, a randomized trial or survival curves will not, in fact, for me, help in selecting which patients are useful to go for surgery.
Pietro, I respect your point of view, absolutely,
I think
you are right.
It's yours also.
But those patients who are referred to the surgeons by the medical oncologist are the patients for them, if the breast cancer is stable, there are metastases in the liver, I think that it's a kind of salvage surgery for the patient. I think that's, I don't like to use the term compassionate because it has some academic or scientific principles or basis. But in general, if we are ready to uncomplicated future liver surgery, we should offer. That's my opinion.
I was saying the windows, in fact, for me, is not for those patients. It's for other patients that we find good chemotherapy. So say, if you operate on this, I can stop the chemotherapy for 2 years and just leave them on a very non-toxic maintenance treatment. These are the kind of patients, I think, that are good for resection,
Yes,
not the compassionate ones.
That's the evolving indications for non-colorectal, and not only breast cancer, but also other
I think that this is the story of the breast metastasis in the liver. This is from conventional to the future, because explain very well the conventional treatment of the colorectal, the history of the breast metastasis, but the future is changed, like Piero said, because the PET scan
many imaging difference, so they have a specific treatment, even extra hepatic disease.
Yeah, René.
Just a comment to what was saying by Pietro, in the fact that for resecting a patient with liver metastasis from breast cancer, he should be convinced by the oncologist. I would say it's a reverse attitude. We have now resected more than 200 patients with breast liver metastasis with a policy very simple. Patient very well controlled by chemotherapy, and oligometastatic disease. We will not go into a half procedure for breast liver metastasis very simply. And so by this way, what we show is that we have a 42% 5-year survival, and we have long-term survivors. We have now 15 patients alive, disease-free at more than 10 years, which is impossible to obtain with only systemic therapy. And for me, this is the most stronger factor encouraging me in proposing a liver surgery for oligometastatic breast, well-controlled disease. And so I don't need to be convinced by oncologists. What we need is to convince oncologists to refer such type of patients.
We all agree. We all agree about that. The point is, you showed, nevertheless, that the biological status, and particularly RR are really important in the prognosis. My question is, if you have a patient positive, RR negative, do you contraindicate her to surgery? Because it seems to be a very important factor.
Yes, you're absolutely right. It's a very important factor. But so far in our principles indication to the surgery, we did not take it into consideration. Okay. That's a kind of a pilot study or a pilot indication.
That's the limit of those studies. Okay, Rashad.
Thank you, Christophe, for your excellent presentation. I'm not going to comment on it. It's just the first thing about the incidence. The incidence has changed. According to the WHO, since last year, breast cancer is #1 in the world. #2 is the lung cancer. And then as a cause of death, breast cancer has moved from the 2nd cause of death to the 5th cause of death from cancer all over. And that's because #1, early detection, #2 is multimodality treatment.
I appreciate your comment.
Thank you both.
Both, yeah.
I'm sorry.
We have a little time. So it is possible for anyone who has a talk tomorrow but is ready to give it now, we can accept that talk. If anyone wants to volunteer to do that.
Ready? Philip? It's
Hugo.
It's not a talk, it's a film. It's good to finish by a film. You have a wonderful film with a lot of anastomosis, as usual. You want a lot of anastomosis?
You want to do 2
and
or
pancreatic surgery? You want? Okay, we finish like that?
Okay. Provided it ends well. Okay. Yes, okay, come.
We wait for you. It is in the box? Okay, it's ready, so...
Okay, so we ask
probably.
Yeah, we need
probably. Yes. No, this is who is this?
I think,
who is this?
I think Hugo is also ready.
Hugo, Philip, maybe I can move the program of tomorrow today, or by night. Okay. With pleasure, Philippe Bachelier's modified, extra modified apple bite technique for locally advanced pancreatic adenocarcinoma.
Hello, everybody. No, not yet. Not yet.
after the video, maybe. First, where is Guido? Guido is not here. I thank you very much, my good friend, for these invitations and the opportunity to relax the audience by this video. So, not yet. Yeah, okay. No, we can stop it. Yes, a little bit. No, I just want to say one word before we start the video. As you know, locally advanced pancreatic cancer could be treated in selected candidate by surgery associated with chemotherapy, preoperative or postoperative chemotherapy. And the difficulties, the concern with this surgical procedure is very linked to the obstruction of the venous system, portal system, mesenteric vein, and so. And the main details for this procedure are linked to the resection of the pancreas without ischemia of the liver, and ensuring during this dissection the portal inflow and the outflow from the bowel, and the reconstruction of the venous. Because my opinion now, after experience, to resect or reconstruct an artery is very easy. You need a stump, a proximal stump, a distal stump. It's very easy. You stitches the both sides. But what is very, very important is the venous drainage. If the venous drainage is not efficient, you have a venous thrombosis. If you thrombose the vein, you occlude the artery. That's very, very, very important. So that we develop, like as a Japanese surgeon, we develop a shunt. And we will see on this video an example of this procedure using for apple bite technique, transitory mesenterico-portal shunt. So we start with the video. I think here. Yes. You will see the detail of this patient. It was a young woman, 46-year-old, with a huge tumor you can see here of the neck and the body of the pancreas. And we decided to do this apple bite procedure. So when there is a blockage of the venous axis, we are used to mobilize all the colon on the left side, on the right side, and mobilize all the block, duodenopancreatic block. So you can see this dissection here, the right colon and the duodenum, and we free all the tissue around the duodenopancreatic block. So here, dissection of the superior mesenteric vein, just below the tumor. The tumor is located just above my finger here. We located the superior mesenteric artery with we spot it here, you can see. And after that, we do the dissection on the top of the neck of the pancreas, freeing here the gastroduodenal artery and the distal part of the hepatic artery. We put a tape on these arteries. So we do a cholecystectomy just to have a look on the hepatic pedicle. Here we mark and we tape the hepatic artery in order not to cut it during the dissection. And we extend the lymphadenectomy to the left part of the pedicle, hepatic pedicle. So we tape all biliary duct and hepatic artery, just to have a good space on the portal vein. So we measure the diameter of the supramesoteric vein to choose the good shunt. We use ringed Gore-Tex to do this shunt. You can see it, the white tube. And we implant this Gore-Tex on the proximal stump of the supramesoteric vein. We do the stitches, the suture, end-to-end, using proline. That's very common. And we put this shunt, we close the other stump, obviously, and we put this shunt out of the operative field. Usually it is on the right side, as you can see, and we implant the top of the prosthetic graft, the Gore-Tex, into the lateral side of portal vein. As soon as we did that, we can unclamp, and we never mind during the rest of the operation about the drainage of the bowel and the vascularization, portal vascularization of the liver. So in this patient, she had operation for varices on the legs, so that saphenous grafts were not available, so that we decided to reconstruct the hepatic artery with a segment of splenic artery, as you can see, with it's a distal segment, of course. Here we have cut the left venous gastric vein, and we taped also the artery. And now we cut the neck of the pancreas, but at the junction between the neck and the head. So we are just on left side of the gastroduodenal artery, as you can see, just on the top of the right angle. So doing that, we reach here, we can join the proximal part of the portal vein, just above the venous confluence. We tape it, and because we have done this shunt, venous shunt, we can here, as you can see, cut with a stapler the portal vein. We do that, so now we can do the dissection around the different arteries. There were no involvement of the SMA in this case. Sometimes there is, so that we have also to resect and reconstruct the SMA. And afterward, we do the lymphadenectomy, and we remove all this lymphatic tissue around both arteries. Till the aorta. So we use this device, which is very convenient for coagulation and section at the same time. So this dissection, we remove all the lymphatic tissue and the splanchnic nerves between the celiac trunk and SMA. Here we individualize the left adrenal glands, and we mobilize also the splenic and left pancreas en bloc. We cut the omentum, the left part. And in this technique, which is a modified apple bite technique, we keep the stomach. I remind you, the apple bite technique is already, we call that apple bite technique in the pancreatic resection, but it is already a modified apple bite technique because we keep the stomach. In this extra modified, we also resect not only the hepatic artery, but also the venous axis. So you have seen the different dissection. Now, to reconstruct the venous axis, we decided to use the left renal vein. We remove all the tissue around, and we clamp and cut this left renal vein just downstream the adrenal vein and the genital vein. So that very often there is no need for venous drainage of the left kidney, and it is efficient. So you will see at the end of the video, we will test the tension into the stump. If there is too high tension, we have to implant this renal vein into the inferior mesenteric vein. So before to reconstruct the vein, we reconstruct the arteries. So we cut the left gastric artery. We cut also, after clamping, the common hepatic artery. You will see here arterial flow. We have further to maybe to discuss about the necessity or not to reconstruct these arteries. Sorry? Not yet. I discuss now.
Okay.
Thank you. Yeah, comment after. So, now see, if we do that, we will lose something. Okay. We cut here the proximal stump of proximal part of the celiac trunk, and we finally remove the specimen with en bloc resection of the confluence of the venous confluence and celiac trunk and hepatic artery. So, as decided before, we reconstruct the hepatic artery using this segment of the autologous splenic arteries. It's arterial anastomose. We use stitches X0, coralline X0, using loops, not loops, magnificent glasses. We do that with the first one. And we implant the distal part of this graft into the stump of the hepatic artery, as you can see here. Same technique. After this arterial reconstruction, here you can see we kept a branch of the splenic artery, and I decided to cut this branch and not to implant into the left gastric artery, because when we reconstruct this artery with a good diameter, you can see here, there is a pulsation, good pulsation. There is no need to reconstruct left gastric artery. So the time is now for the reconstruction of the vein. We clamp here the portal vein. We cut the stapler line. And during all this time, there is always inflow, a portal inflow in the liver. So doing this technique, we reduce significatively the time of clamping for the venous resection or reconstruction. So we reconstruct using the left renal vein graft. It's a common suture, end-to-end, using also proline 6O. That. And what is important when we do that, we have to do some mark on the, you can see the color, the blue color on the vein to put on the right, and we do a frozen section on the cutting edge. So now we reconstruct with implantation of the SMV into the left renal vein. And now there is a clamp. We have to clamp. The shunt is not functioning. And the duration of this occlusion of the SMV, so the portal axis, is about, it's the time to reconstruct, it's about 15 minutes. So now it's finished, and we have to remove the Gore-Tex. We unclamp the portal vein, which is reconstructed, and we have to remove the Gore-Tex on the right side of the portal vein. It is a lateral clamping without any occlusion, as you have seen. So you can see here the stomach. We test the tension on the stump of the renal vein. Here it was not in tension, so that we decided not to implant in the inferior mesenteric vein. We test with ultrasound the quality of the artery, hepatic artery, and we finish with the drain. So we usually do at the postoperative day 1 a CT scan just to check if there is no thrombosis of the arteries. You can see here. And 1 year later, there is also artery patent, and what is most important is there is patency of the venous axis, which was reconstructed. This patient was operated in 2021. She's still alive, but recently appears liver metastasis. Thank you very much for your attention.
Thank you very much. We have some questions.
Professor,
microphone.
Congratulations for the amazing surgery. Just one technical issue for my learning. Why do you harvest the left renal vein and you could use the prosthetic graft you had already in place with one of the anastomosis done already?
I don't like prosthetic graft because the patency, there's many publications about that, of the length of the patency of the prosthetic graft when we reconstruct the portal vein. And after 6 or 1 year, it is occluded. So when we do this kind of surgery, my ambition is to maintain alive the patient for long. We don't have time to discuss about survival, but in our experience, we have now for the patient without oligometastatic disease, more than 170 patients, we have a 5-year survival, which is 40%. So 5 years, it's not 6 months, it's not 1 year. And if there is an occlusion of the vein, there is a lot of consequence. You know that very well. For the bowel, there is a discomfort and hemorrhage, maybe. So we don't use prosthetic graft. We have to use something because when you resect the confluence, you resect the minimum, the minimum length of the vein is 3 centimeters. Between the two stumps, portal stump and mesenteric stumps, there is the head of the pancreas. You cannot pull. So that you have to use something. The solution was described by the Japanese author using this left renal vein. And when you use the left renal vein, you have to check, as I show you, if there is tension or good drainage of the left kidney. If there is no good drainage, you have hemorrhage on the left part of the retroperitoneal. So that it's very inconvenient. The second possibility, if you want to use a biologic tissue, is to use a saphenous graft. You do angioplasty, a tube like Lee described for the hepatic vein, or cryopreserved tissue. But this kind of tissue are not very common because not very good because there is also as a graft thrombosis. So we try to use a renal vein or saphenous vein.
Okay, thank you. So Pietro?
If the stomach had not been in good shape, what you would have used to reconstruct the artery?
Yeah, it's a good question. You know the big series of the north in Europe with no reconstruction of the hepatic arteries. There was what was the question?
One of the risks of this procedure is having to cut the left gastric artery, then not having the spleen and then the stomach living on what? On the right gastric, and it's very little. And the Japanese have described reconstructing the left gastric on the middle colic.
Yes.
What do you advise?
Yeah. Yes, in this case, we had the opportunity to reconstruct it because there was a branch, and my first idea was to do that, but it's difficult because the left gastric artery is very, very, very small. If you increase the number of arterial anastomoses, you increase the risk of thrombosis. So I think the most simple is more efficient. So we look at the end. After reconstruction of the artery, we look at the color of the stomach, and especially the high parts of the stomach. If it looks gray, it's not good. You have to do something else. But what is what we observe very oftenly is this gray aspect of the stomach, of the high part of the stomach, when we have clamp or remove during the time of removal of the hepatic artery. And it vanished when we reconstruct the hepatic artery. Because when we do this technique, we keep the pyloric artery, and we keep also the gastroepiploic, the right gastroepiploic artery, so that when there is a good inflow into the hepatic arteries, there is no need to reconstruct the left gastric artery. In the experience of the Japanese surgeons, they don't very often reconstruct the hepatic artery, so that they have to reconstruct the left gastric artery. It's very important because if you don't reconstruct one of these both arteries, it's not sufficient to arterialize the stomach. The first, I remind the history. The apple pie was described by a Canadian, if I remember well, surgeon, and it was applied for gastric cancer involving the pancreas. So he removes both. If you keep the stomach needs a lot of blood. So you have, in our policy, we systematically reconstruct the artery. And we don't mind if it is closed or unclosed. And so we don't do embolization. We systematically reconstruct the artery, hepatic artery.
Question was in the same line that Pietro. How do you check the safety vascularization of the stomach? But you already...
With the color. With the color.
The color.
Recently...
Sometimes the venous return is not good. Maybe the artery is the color, but the venous deprivation...
But you have seen there was big vein on the stomach. These big veins, this dilatation was induced by the portal hypertension, induced by the occlusion of the splenic vein. So there is big vein. But at the end, the venous drainage is done by the top and the low part of the stomach.
Great.
And we now
for this fantastic video.
But recently we bought a new Doppler. It's a Medistim. It's a special for the vascular surgeon. It's a very small sound, and it's very convenient to check the flow into the artery which was reconstructed.
So maybe you will not reconstruct systematically the artery, the hepatic artery, with this device.
Maybe.
Why do you?
Yes,
are you ready to discuss that?
Maybe, but I don't want to play Russian roulette with the patient.
Why? There is the gastroduodenal, which is, look at that. When you cut, there is an excellent outflow, pulsatile outflow.
No.
It doesn't need. You said yourself. If you do anastomosis, the risk of thrombosis.
Yes,
so you create the risk of thrombosis.
As René said just previously, we have to convince everybody that is the right way. No, I think we can do a study if you want. You cut the left pancreas without reconstructing.
That's why I'm doing.
Systematically.
That's why I'm doing apple pie. If the gastroduodenal is good, I do not reconstruct the hepatic artery. Maybe I have not your experience, but for the moment it's good. And Del Perro, your friend,
yes,
is doing an embolization of the hepatic artery before to improve the outflow by the gastroduodenal. So I don't know, it's really useful, but it's Del Perro, not me, Del Perro.
Yeah, I know him. But
do you?
But even the Japanese surgeon don't
they reconstruct, Japanese surgeons?
When they do embolization of the arteries, the results are not so good. I discuss with them, it's not so good. So very, very often they have also necrosis of the stomach. So I think the best way, is my opinion, you resect an artery which was not occluded, you have to reconstruct the artery. The results of the embolization before operation, I think there is a too short time between the embolization and the operation, so that there is no time for a good arterialization from the gastroduodenal artery. We have now, we can study that. Probably in the next patient we will do systematically the use of ultrasound with
Would be interesting.
The results of the measurement of the pressure.
Would
So
be interesting.
maybe.
Philippe, great operation. Just one observation. I use as biological graft internal jugular vein, autologous internal jugular vein. Do you have some experience about this? Because it's longer, it's almost the same caliber between portal and mesenteric vein, and I find it very useful.
We did that before. It's a good graft, very good graft, good, longer than the renal vein. But doing that, you have to push the anesthesiologist. So it is a major inconvenience. So
I push the anesthesiologist before the operation.
Yes, but
so I prepare already the neck.
If finally, when you open, you discover carcinomatosis and you cancel the operation, you have removed the vein of the patient?
No, because I take out the vein once I'm sure that it is resectable.
Yes, but it's not very convenient.
Okay, we'll just quickly, Pietro, because Hugo's giving the last talk. Yeah.
Yeah, on the last line, a good option that our vascular surgeon in Geneva used is the superficial femoral anastomosing the distal bit to the deep femoral.
It's also a good option, yes. Yes, I agree.
Thank you, Professor Bichali. Excellent.
Thank you very much.
Yeah. Okay, we have the last talk for today. Hugo is going to talk to us about robotic surgery for perihilar cholangio.
Let's change a little bit, if this works.
Yes, it is.
And that I have to switch because
okay.
Let me check if it is running.
Okay, so we move to this other completely different topic. I would like to thank Professor Bismuth and Guido for the opportunity to present our work here. And we are going to talk about robotic hepatectomy for perihilar cholangiocarcinoma. As you know, hilar cholangiocarcinoma is often regarded as a tumor in a very difficult location because it's located near the bifurcation of the portal vein, near the right branch of the hepatic artery, and in fact, it is often referred to as extrahepatic, to the biliary confluence as being extrahepatic. But in fact, if you resect the biliary confluence, you are deep inside the liver. So in fact, the biliary confluence is not at all extrahepatic. So hilar cholangiocarcinoma is a parenchymal disease in a location with difficult access. As you know, of course, the most adopted classification for hilar cholangiocarcinoma is the Bismuth classification. You know there are 4 types of Klatskin tumors, but in fact, Professor Bismuth has even described a 5th type that is very difficult to find in the literature, but often referred by Professor Bismuth as a 5th type that spares the second branch order of the left confluence, spares the branches for 2 and 3. This is an example of Bismuth type 3A hilar cholangiocarcinoma. Perhaps due to this location, the only approach that has ever been considered for perihilar cholangiocarcinoma is the open approach, is the approach that is most widely used. There are some reports of some very scarce experience of laparoscopic resection of perihilar cholangiocarcinoma, but in fact, it is very, very rare to see this type of descriptions, and they are probably much more difficult to approach than by the robotic approach. And using the robotic approach, we have some advances about donor hepatectomy being done by the robotic approach. Fabrizio is going to speak to us about that tomorrow. Reports of vascular reconstructions being done by robotic approach, and also some small series of hilar cholangiocarcinoma resected by hilar approach. This systematic review summarizes a total of 109 patients in the whole literature in robotic approach, and as you can see, in fact, there are very few reports of series of robotic resection of hilar cholangiocarcinoma. There is only one series in the Western world reporting hilar cholangiocarcinoma being treated robotically, and there are several series from Asia, but in fact the largest series show that in 21 patients, in fact only 3 of them were treated by liver resection. In the Western series, there is an Italian series of 4 patients. In fact, in those 4 patients, in one there was a conversion, but we can see that apparently the results show that this is at least feasible, and with a post-operative stay that is probably shorter than in the open approach. If we look at our own experience in Lisbon, we can see that this is the total experience of our activity in HPP surgery, and you can see for liver surgery the numbers of last year's, 471 patients operated last year, and you can see that the percentage of patients that are operated by the robotic approach are increasing. And you see here, for example, that when we started the program in 2019, we started by simple operations, anatomical segmentectomies, right or left hepatectomies, and then we moved to more complex operations like mesohepatectomy, reconstructions and resections and reconstructions of the bile duct, and then we started performing surgical treatment of Claskin's type 3B and 3A, and after that, portal thrombectomies and even IVC thrombectomies. This is an example of a patient with a type 3B hilar cholangiocarcinoma, and I'm going to show you this video for you to see that, in fact, we can replicate the technique that we are using in open surgery. This is clearance of station 8 around the hepatic artery, the common hepatic artery. This is clearance of station 12. And we can see here clearance of station 13. This is a classic place of recurrence in perihilar cholangiocarcinoma. This patient, as many others, have right and left replaced hepatic arteries, so it's frequent to have this type of variations, of course. Now we are approaching the bile duct and sending bile duct to frozen section. We are using internal external drainages now. This is distal bile duct. Right replaced artery from SMA, common hepatic artery. This patient has also a left hepatic artery for the left liver, of course. So we are sectioning the common hepatic artery. This is the left branch of the portal vein. Then we cut the left branch and we continue the resection. And we do it this time, at the same time, lymph node clearance and dissection of the hepatic pedicle, because we feel that this is, in fact, the best way to gain some time in this operation. Clearance of station 7 nodes next to the left gastric artery. This specimen had 14 lymph nodes. This is the common hepatic artery. This is mobilization of segment 1. The common trunk of middle and left hepatic vein is taped for orientation of the resection. We see here. And we have two options. We could do a left extended hepatectomy or left resectionectomy. We opted for a left extended. This will give us probably more ducts to reconstruct, but as long as we have a clear margin, it's a good option, we think. And this patient was resected. The liver resection timing was one period of 15 minutes of pedicular clamping. And we are approaching the bile ducts on the right. And we are cutting, as you see, the bile has good quality, fortunately. It's not an infected bile in this patient. Frozen section of the proximal bile ducts. We have 2 ducts here. And finally, we continue the hepatectomy in the right plane for a left hepatectomy. We gained again the plane of the middle hepatic vein, and we staple and separate the left extended hepatectomy specimen. And then we reconstruct a Roux and Y for the hepaticojejunostomy that we do in transmesocolic, although it can be done anticolic. It depends on the patients, of course. And then, in this case, we had 3 ducts that we could reconstruct in a single hepaticojejunostomy. And this is one of the main advantages of the robotic platform that allows us to perform this type of reconstruction, in our view, much more easily than if we were doing, for example, a laparoscopic approach. So the posterior part of the anastomosis. Then we have the anterior part. And one of the advantages is, in fact, the improved visualization that we have with this type of technique. We can see here 13 lymph nodes, 4 positive. It was 2A and 2. So, in fact, the thing that impressed us the most with the first cases of perihilar cholangiocarcinoma was the post-operative, because there is less, we see much less complications in this type of patients when we compare them with the open approach. And you can see that if you compare the 6 first patients with 6 patients done by the open approach at the same time, in fact, one of the most striking things is the hospital stay. But, for example, the bile leaks are very infrequent in this type of approach. So now, and we have also our co-author Fabrizio here, this is the first paper on perihilar cholangiocarcinoma for robotic approach. It's the first multicentric series that was done. It's not published yet. This is the preliminary paper, and you can see this was done with Lisbon, Modena, and Tampa. 9 patients in Lisbon, 13 patients from Fabrizio de Benedetto here in Modena, and 16 patients from Tampa. And you can see that, of course, the operative duration is long, 481 minutes median. Estimated blood loss is very low, in fact, 200. We have 1 unplanned conversion, and we have 5 type 4 hilar tumors. The most frequent operation performed in this series of 38 patients was left extended hepatectomy, although we have 11 cases of central hepatectomy. This is unusual. This is the option they took in Tampa, in Florida, to treat type 1 and 2 patients, and that is why there are so many patients with central hepatectomies for hilar cholangiocarcinoma. You can see the number of lymph nodes harvested, the median number is 7, and we can see that 2 patients had vascular resection and reconstruction. 81% of the patients had R0 resection. For complications, we had 6 patients with grade 3. Median length of stay was 6 days, which I think it's very, very good, and we had 1 patient with mortality. This is some of the first cases of vascular resection for perihilar cholangiocarcinoma performed robotically in our knowledge. This is our case in Lisbon. It was a type 3A. So in this patient, the discovery of portal vein invasion was intraoperative. You can see here the specimen with 22 lymph nodes, and we can see here the lymph node clearance, where you can see all the vascular anatomy of the region. Now you can see invasion of a portal vein. We are performing the right extended hepatectomy under Pringle in this case. And then we are arriving to the left bile duct that we can see here. And we are now first doing a section of the left bile duct. We are doing frozen section, of course, and then we go to the portal vein resection, which is the last part. We decided to use a stapler. This was not an excellent idea because we lost some length, and so the anastomosis was a little bit more difficult, although not at all impossible to do. And this is the reconstruction using 5-O-proline. So the posterior part of the anastomosis is almost finished. We are now in the anterior part. And you can see the final aspect of the portal vein after reconstruction that you can see now. After this, we have the ductoplasty and the reconstruction with the ruined Y. And finally, this is the final part of the operation and the Doppler confirming good flow. So I took the opportunity and I asked Fabrizio to show me his own video from Modena for type 3B. 3B, yes. So we can see here the portal vein resection using clamping. Fabrizio decided to use a clamp in the upper part. I think it was a smart decision because he had a little bit more space to reconstruct. So cutting the portal vein and then the main trunk. And then you can see the reconstruction. Posterior parts and then anterior parts. And this is the final aspect, and you can see unclamping of the portal vein. That's it. So in the first experience, we can also present a preliminary survival for those 38 patients. And you can see that, in fact, the survival of these patients is above 40% at 5 years in this first multicentric series. And I will finish saying that, in fact, world experience in robotic liver surgery is still scarce. Surely there is more data that is necessary to allow an adequate comparison with open, and why not with laparoscopy, but I think open much more important. And hilar cholangiocarcinoma being done robotically is an experience that should be reserved to highly experienced centers, but it looks to us that this is probably one of the most promising applications of robotic surgery. Thank you.
Fantastic, Hugo. We're going to ask you to stay there. We won't do the discussion just yet. We have the honor of the chairman or CEO of Humanitas, who would like to say a few words to us. So I'd like you to welcome Mr. Rancharo Rivera. Thank you.
good afternoon to all of you. And sorry to interrupt you, but I really want to thank you, all of you coming here. I mean, all the people who contributed to the organization of these days. I thank Professor Bismuth and Professor Tozzilli, and I'm happy to, on behalf of Humanitas, to thank you for this event. And I guess, I mean, this is really in the heart of what we do every day here in Humanitas, trying to combine high complexity care, high complexity surgery, research, and teaching. So growing new surgeons, growing new medical students, new physicians, trying really to do the best for our patients and possibly for this country being in Italy. Thanks a lot to all of you.
Okay, Hugo, can we have you back up? Yes. Okay, I'm sure
Hugo,
that's going to...
brilliant presentation, excellent surgery. 2 questions. We consider actually all the Klatskins, they're all mostly drained with drains, so we consider them as infected, and we treat them from 1 day before till 7 days, blinded, just always broad spectrum antibiotics. Do you also do that? And secondly, second question then, we also have the vision that sometimes you do portal resections, sometimes you don't. We have a little bit Peter Neuhaus from Berlin. We always do a portal resection, almost always. Or it should be really free. And otherwise, with a little bit of doubt, we just cut it out, always. What's your opinion about that?
Well, I think these are 2 important points. First of all, infection is probably the reason why most patients die after this type of operation. And some years ago, we started a protocol of active detection of infection preoperatively. So we culture the patients preoperatively, and we do blind antibiotic therapy after day 5. And every 2-3 years, we reevaluate the results to adjust antibiotic therapy to these patients. I think at this time it's ceftazidime and metronidazole, I'm not sure, but we are always changing. And this had made a huge impact in the post-operative period of these patients and the post-operative results. On the other hand, for portal vein resection, I think the preliminary results of Peter Neuhaus were never reproduced. And so to do a no-touch resection without evidence of invasion is not our policy now. What we do is, as long as we know that we have portal vein invasion, we plan a no-touch resection. But we never do it on purpose in a patient that has no portal vein invasion known previously.
Yeah, Dimitri, please, yeah.
Hugo, I want to congratulate you so much. How far you have come from the first couple of cases that we did together in Lisbon to now. It's just absolutely impressive. But I just want to echo a lot of the things that you said, because the visualization of these tumors is better. The lymph node harvesting is more precise, and I think the numbers are higher with the robot. And your oncological R0 resection level is higher with this approach, because the way you visualize and the way you're able to reconstruct these bile ducts robotically with magnification almost over 20 times bigger, you have an extreme precision, which leads to less complications, shorter hospital stay, and overall better oncological outcomes.
Totally agree. I think this is one of the main advantages, yes.
May I say something? Of course. Professor Bismuth, I learned one thing from you also. That's the obligation that we have, all the Compagnons, when we leave and when we go, because we finish our activity, to give opportunity to the people who stay to do better and that. Sorry. So I am very proud because this robot was the first robot for a public hospital in Portugal, and I fight for this robot when I was 69-year-old already, and I knew that in 1 year I went out. And that's not the reason not to fight, to give to Hugo. And I am very proud now to see that's one of good things that we can do. That's for our teams and for our groups. That's to give opportunity to people who are going to stay, to have the conditions to do even better. And that's the message, that's the responsibility that I think that Compagnons have also to have this. So, Hugo, I think that's a good idea. And I went to Pakistan to have this robot 1 month after I have my heart attack with the 2 stents. So I have the protest not to go, but I went there, and okay, that's that message I want to give you.
Hugo, you said, your last sentence is that the robot is necessary and you think has better result than open surgery in this very complicated, extreme liver surgery and biliary surgery. What do you mean? You mean that we HPB surgeon, we need now to introduce the robot in the extreme part of our technique?
Yes, I think so. I think the 2 main messages I wanted to say is, first of all, it seems to us in this very early experience that this may lead to better results in this particular group of patients. We see this in the post-operative period. We think so. And on the other hand, we think that every HPB center, every specialized and referral HPB center will probably have to have a robotic platform in all the armamentarium that they have, because I think this is a very important tool, probably for this type of very advanced surgery.
And you say it seems to you to be better than laparoscopy, and you say better than open.
I think it is better than open in some cases, yes. We think.
Yes, I think that for reconstruction phase is better compared to the laparoscopy, but usually we perform the liver resection in perihilar in very selected cases, not in all cases. So in my center, we perform only 13, up to now, 18 cases. But usually we perform in open, with open technique. In very selected cases, we perform with the robot the liver resection and reconstruction. Not in all cases, in my center. Because usually, as you know, Professor Bismuth, the patient had very advanced, so.
What are the indications of open surgery now?
In my center, portal resection usually is indication to approach this patient in open way, and very complicated cases like portal and artery infiltration. So we usually approach the patient with the robot in very selected cases. But if you do artery resection and portal vein resection, we can do open in all patients.
We have to say that.
You know, there was one case reported of robotic liver transplantation. Not only the donor, but also the transplant. We are very, very reserved. And you know the reason.
You are right. I think that you are right in This is an initial experience, Professor Bismuth. So we have this is a 3-center, 38 patients. So this is an initial experience. So we have no data, but usually the classic way, open way, is the best for me and for the moment, for all patients. So the liver transplant is also living donor liver transplant, and whole liver is very promising indication. And the robot in my center for perialar we use usually to do a lymphadenectomy before liver transplantation. So it's very, very interesting to use the robot because it's very easy compared to laparoscopy in the setting of liver transplant. So I totally agree with you, and I think that we stay at the beginning of the activity to approach the perialar with the robot for the moment.
I can say, for example, for now that we have probably the same numbers. We should be reaching 20. And what we are doing is like we are starting to propose more and more patients for the robotic approach. So we were being very restricted at the beginning, and now we are starting to be a little less restrictive. But we are still putting the worst cases in open, of course.
For example, for now, we have no idea in the seeding after the mini-invasive approach. If you look at the literature, we have no data about the seeding inside the abdomen or at level of the trocar in abdomen or at hilum. So this is a problem for us because we will see in the next future if we have the same problem like in open.
I think that my avatar will start doing robotic surgery in the metaverse.
Okay, thank you, Hugo. We'd like to bring it to a close. Thank all the speakers, the discussants, and all of you as well. Guido, is there any announcement for tonight? The bus is here, but for tonight, is there any announcement for the dinner?